হ্যালো হ্যালো ঠিক আছে हेलो हेलो ठीक है अरे यार हेलो ठीक है हाँ ओके थैंक यू good morning everyone and welcome. So on this beautiful Sunday morning, it's very difficult to get people coming and on holiday and have this meeting. Thankfully we have faculties of national fame sitting in our hall. But first of all, we have seen a tragedy in nearby area where, where my friends are working there and they have informed that around 1,000 lives are lost because of train accident. So first we like to pray for them and then start our meeting. So I'll request everyone to stand for 2 minutes and pray for those departed souls. Thank you. Thank you. MEDICA is committed to bring the best in healthcare, keeping the same motto. For prostate, I think holmium laser surgery or HoLEP is best, as claimed by people, urologists. We feel if it's best, then we should be doing it. We should be providing the people the services here. And it's always a time to learn and relearn something. So we have been doing these surgeries, but we wanted to maybe other people in our fraternity learn it as well and pass on the message, pass on the technique, tricks to the future generations. We have the best technologies available. We have the best surgeons available. But to pass on this baton is very important. Thankfully, we have the best faculties in our country coming today to operate and teach others how this technique is useful, how this technique can be mastered and passed on for betterment of society. I would like to thank Ambreen, our secretary, Dr. Sinha, the chairman, and Dr. Mishra sir. He is the founder of this Department of Urology in this hospital. And Dr. Srinivas for coming from Fortis Hospital, and Dr. Tanuj, my friend from Faridabad, for this program. Thank you also. We'll be starting, we have around 5 cases kept today. We'll be transmitting it here. And Dr. Mishra is there to moderate, Dr. Sinha is there to moderate, and I wanted to make it a semi-formal kind of event so that people can be free to learn and ask questions, and whenever they feel that they need some clarity, they can be, it can be made there. Thank you. Sinha sir, want to say something? Dr. Mishra, yeah.
Thank you for inviting me. I believe, to my mind, prostate surgeries today, HoLEP being, as he told, it may be the best procedure, but it's not finding its right place even today. There are many, initially when I thought of HoLEP, why it's not catching up, probably it was cost, because the availability of the equipment. But you'll be surprised to know there are several equipments available in hospitals which are not used properly, which is not used to its fullest potentialities. The reason to my mind lies with the learning curve. The middle-aged urologists who want to embark upon HoLEP, they think they have a large experience of TURP, so it's just another step up. But it's an entirely different procedure, and to learn it, you need dedication. Steady flow of cases, and proper mentorship. If you don't do that, probably we land in a situation where we are not doing it properly, we are not able to cross the learning curve. People can do HoLEP, large glands, 100 glands in 30 minutes time. That's nothing very unusual today, people who have crossed the learning curve. So to achieve that kind of perfections, you need dedications, you need steady flow of case to be provided to a man. I believe it is easier for the residents who has not mastered TURP to learn a HoLEP, because he's learning the way the mentor is telling. But if you have already doing a large number of TURP and you have a reasonably good result and you want to learn HoLEP, it becomes more difficult than because you have already, there's always an easy escape route. So whenever there is a bit of problem, we think I will band karo isko, let's go back. The instruments are always there in the trolley. So that's probably the biggest stumbling block in bringing the popularity of the HoLEP. So I believe it's a welcome measure Abhay has taken. I believe we should carry on with our efforts to crystallize this technique and bring the good things to our patients. Thank you.
स्टार्ट करते हैं मे बी कम चलिए तब तक स्टार्ट करते हैं मे बी चलो हम लोग आ रहे हैं स्टार्ट करो ना ट्रांसलेशन चेक करके बोला इधर स्पीकर किधर है? हाँ ठीक है। HoLEP करना।
Check. Hello. Raju.
I prefer 1.2 or 1.5 कम करेगा।
छोटो হবে
1.5 कर लो।
राजू
फ्रीक्वेंसी 50।
হ্যালো।
হ্যাঁ শুনতে পাচ্ছিস স্যার কিছু
হ্যাঁ,
বলছে একবার দেখ
और मोजेस अगर फाइबर मोजेस यूज़ करेंगे तो मोजेस ऑन कर लेंगे, ठीक है?
স্যার বলছে
কলার মাইক বন্ধ আছে নাকি? হ্যালো,
অন আছে অন
हाँ
আছে
वही वो मोजेस आते ही वो इसीलिए मैं वो
কলার মাইক অনেক লো আছে,
আচ্ছা
ওটা
বাড়ি
বাড়াও।
দিচ্ছি
बोल देंगे। एक पिक्चर ले लो मशीन के साथ। हेलो,
আরও বাড়বে।
कैन यू हियर मी? हेलो,
কলার মাইক বাড়াও, অনেক আসতে আছে।
हेलो, कैन यू हियर मी नाउ? आ जाओ डॉक्टर साहब, आप फोटो।
Hi Tanuj. Hello.
सर कैन यू हियर मी?
Yes, yes, very well, pretty well. Thank you. क्या चल रहा है अभी?
या अब आई थिंक द पेशेंट इज जस्ट गेटिंग रेडी। सिस्टर इज रेडी विद द स्टेथोस्कोप। अगर आपका लेक्चर हो गया तो वी विल स्टार्ट विद द स्टेथोस्कोपी।
No, you start the procedure. After this, I mean, this surgery will have one lecture.
ओके।
Yeah. अच्छा, can I have brief about the patient? अमरीन को पता होगा. So,
आप केस प्रेजेंट कर देंगे? केस प्रेजेंट कर दीजिए
अमरीन.
जल्दी।
Yeah.
Sir, can you hear me?
Yeah. अमरीन, चलो बताओ.
Sir, 81-year male patient.
81.
81.
Okay.
Patient complaining of acute urinary retention 1 month back. Voiding trial failed. Ultrasound 81 cc prostate with large median lobe.
Okay.
PSA was 3.19.
So patient 81, prostate भी also 81.
81, yes sir.
Okay.
Yes.
Okay, great. Okay, large median lobe.
Yes.
Okay.
And
Anything else?
PSA 3.19.
Fantastic. Okay.
So we'll start with the cystoscopy, sir.
Okay.
As
Can you change the camera?
Yeah.
81 gram prostate. Yeah.
Can you see the endo view?
End of view नहीं है अभी. Change the end of view. Yeah. Yeah.
Endo view दीजिए please.
Okay.
So we always look at the urethra how it is. It's a nice roomy urethra. That's the verumontanum. We look at the anatomy of the prostate. We can see there are large lateral lobes. Going ahead, there is a large, very large median lobe also.
Okay.
I think this is more than 80, sir. We cannot rely on ultrasound for prostate volume. It's a highly trabeculated bladder. As of now, I have not seen the ureteric orifices. I'll try to see, but let's see if we can see the orifice anywhere. I think they are behind the median lobe.
It's the same.
Yeah, there.
Same.
That is one
yeah,
side.
Right.
So we should note the position of ureteric orifices so that when we are enucleating, we should keep it in mind and just try that we do not injure it. So on left side, I'm not able to see easily. We'll see later after the BNI. So that is one of the tip actually. Yeah, that's the orifice. In case we are not able to see also, after we make bladder neck incisions, generally we are able to see. So that's a large median lobe, sir.
Right.
That's the bladder, highly trabeculated, casing lateral lobes, and that is the verumontanum. This is the verumontanum.
Okay. Great.
So I always do a Otis urethrotomy for every case because although this urethra is okay, but earlier we were getting some strictures and we were wondering that we are not using any current and cautery, still we are getting strictures. So we started doing Otis for every patient. That gives us more space, it makes the urethra more roomy, and it really brought down our stricture rate.
Okay. एक मिनट.
So sister, इसका marking किधर है?
अच्छा तनुज.
Yes, sir.
have you noticed any difference in stricture rate in a patient who is, on catheter for a long period of time before surgery, and compared to other patients who are not having any history of catheterization before surgery?
Yes, sir. Anybody who's on catheter has more risk of developing a stricture. So longer the catheterization time, longer the chance of stricture. Of course, the urethra becomes more roomy during the surgery, but that should not give us a false reassurance that this patient cannot develop a stricture. Just give me a moment, sir. इसमें मार्किंग नहीं है सिस्टर, वो घूमता है ना, मार्किंग आगे जाता है. ओ यूज हो के मिट गया. पता कैसे चलेगा? ओके.
अच्छा.
हाँ.
You got the Otis?
I got the Otis, but they are saying you used it so much that the markings are gone.
What size you prefer to do it?
I dilate till about 30 or 32, sir.
Okay.
And now I'm doing with the rough estimate. Just hold this straight. It essentially does a meatotomy only most of the times, but some cases it helps in the manipulation later also. And sometimes towards the end there are those nodules which have to be pulled out, then that can be done easily if Otis is done. So multiple benefits of doing Otis, sir. So I'm going in with the resectoscope now with the visual obturator. This is a Wolf resectoscope we are using.
Okay.
26 French.
Senior sir, what resectoscope we have? Wolf.
In my own setup, I use a Karl Storz resectoscope, sir.
Okay. Any particular reason for the choice?
So, sir, you know, when we passed out, it was what we were told is that lower tract is Storz and upper tract is Wolf, what you have to buy.
Right.
So, most of the departments do have outer and inner sheath of Karl Storz resectoscope, and all you need to buy is a laser working element and a oscilloscope. So you save on expense, and of course that is what is available in most of the places. And if you have to convert to a TUR, you can easily do it because you have all the instruments right there.
Right.
So I pass the laser working element. Sister, stool आगे करना please. Laser please. Laser pedal. I hope you are getting a good end of view, sir.
Yeah, fantastic.
थोड़ा स्टूल का हाइट बढ़ा दीजिए.
Oh. Stool is
थोड़ा
designed
height up.
according to Dr. Sinha's
Okay.
sitting position. So.
अच्छा, मैं हैंड से करना पड़ेगा ना, मेरा अनस्टेबल हो जाएगा. It's okay. Let it. It's okay. It's okay. I'll sit on it. Laser pedal. So they are just giving me the laser fiber, and so I'll just tell the steps. So this is a typical 3-lobe configuration. So we'll go ahead with a 3-lobe enucleation only. My first step would be to make a marking right in front of the veru. Is my voice echoing or is it fine?
No, your voice is perfectly right, and
Okay.
the end of view is fantastic.
Okay.
We are just enjoying.
So first incision will be right here, sir, where we'll just make a mark. Also it is said that this is the best place to see the capsule. Now after that we'll use the natural groove. We'll make a 5 o'clock incision from here. We'll move along the groove and come till this particular point, and we'll deepen it till the capsule. Then we'll make the right side incision, 7 o'clock incision from here, and we'll come again to this point. Okay. Then we will connect these two incisions, and we will go on lifting the median lobe.
Okay.
After reaching the bladder neck, we'll separate the fibers. This lobe will go inside.
Okay.
Then we'll come back to the veru. We'll rotate the scope 180 degrees, and we'll make a marking here anteriorly, because there is no landmark anteriorly. And this marking will make a little bit proximally in the fossa so that we save the bulk of the sphincter. The sphincter is sort of a horseshoe shape, sir. So the bulk is anterior, so we make a little distally, the marking, the distal limit of anterior. Then we make a 12 o'clock incision from bladder neck till this particular point. After that, we do the apical release. We make a circumferential incision at the apex on both sides, and then we go about enucleating the lateral lobes.
Great.
Can you give me the laser fiber? Yes. So we'll be using a 120 watt. Sister, pass se pakadiye. Touch to nahi hua kidhar bhi. We'll be using a 120 watt Moses luminous Boston Scientific luminous laser machine today, and the fiber is also a Moses fiber. Nikalna hai.
So is there any difference in the fibers?
The difference in fiber is that this is a single-use fiber, sir. Otherwise, it's a end-firing fiber only. What we are using is a 550 micron. Oh, I think they're changing the fiber now. So Moses, only with the Moses fiber you will get the Moses effect. With the same machine you get non-Moses fibers also, what is I think called as slimline or SIS fibers. With that you will not get the Moses effect, you will get Moses effect only with the Moses fibers. So earlier Moses was proposed as a beneficial thing for stones. But then they realized that it's very good for prostate also. It makes the procedure faster, and also the field is much more clearer is what I have seen. And so much so that some centers in US, in the cases in which they are doing Moses HoLEP or MoLEP as they call it, they are even discharging the patients on same day after removing the catheter. So the results are supposed to be better.
Acha, Tanuj, I'm a layman for this HoLEP. So can you tell me what is Moses?
Sir, Moses is basically a technology from Luminous, wherein sort of a pulse wave travels through a pulse wave. So just imagine first one wave goes, and the second wave, when it passes through it, it little bit dampens it. So in case of a stone, it will pull back the stone towards the fiber.
Okay.
So that will decrease the retropulsion. It's a pulse through pulse, a wave through wave thing. So in a case of stone, it mainly decreases the retropulsion and causes excellent dusting of the stone, sir, which is faster also.
Okay. And how is it better for prostate?
It is faster, sir. How exactly physics, I will not be able to tell you.
Okay.
But this is what has been observed and what has been published also.
Okay. Okay.
So the earlier machines did not allow us to do pulse modulation, sir. Now they allow. So that is also one thing which has allowed us to do better enucleation, because you know, if you keep a medium pulse, that allows you to do good enucleation with the good hemostasis at the same time. This machine has 2 pedals, and because of that we can keep 2 settings. Can you show the settings on the laser machine? So on the left pedal we have the enucleation setting, which is so company generally recommends 2 joules, but I always like to use little lesser energy. So I operate with 1.2 or 1.5 joules and 50 hertz. And once you attach a Moses fiber, pulse width is automatically determined. On the other side is the right side pedal is the hemostatic setting, wherein we have 1 joule of energy and the frequency should be less. So that is 20 hertz, and the pulse width is a longer pulse width. So longer pulse width allows better coagulation. Should I start with the procedures?
Yes, please go ahead.
Yeah. Laser ready, please. Only once we are ready, we should ask them to make the laser ready, so that we don't fire accidentally and damage any of the scopes. So as I said, I'll make my first marking here. I hope you are getting the vision, sir.
Yes, we are.
So as we make this incision, gradually we reach the capsule. And these fibers which we see standing up, these are the fibers of capsule only. The capsule fibers are horizontal fibers. As we incise them, they stand up and they become vertical. We will see this further when we go ahead with the procedure. Is there anyone from Olympus here?
Anshuman is here.
From Olympus, who's there?
Anshuman, Amrin.
Yes, sir.
Yeah, I think Anshuman is there for
Yeah.
Olympus.
Some lines are coming. Can that be decreased?
Yeah, light and flickering is there.
Yeah,
Whatever he was
there is a
seeing on the
flickering.
screen, there is some flickering.
Can we do something about it? Okay, let's see. I'll proceed with the procedure. So this is the 5 o'clock incision site, sir. We start from little inside the bladder neck and we come towards this incision which we have made already. This is the limit. This is the advantage of placing this incision. They are figuring out what can be done for that. In the meantime, I am continuing, sir. So we gradually deepen this incision.
How do you know when the capsule is reached?
I'll just tell, sir. When it is seen, I will tell you.
Tanuj,
Yes, sir.
I'm Dr. Narayan.
Yes,
Why
sir.
there is so much of charring here?
Sir, it's mainly due in the distal part
Yeah.
because in that area I'm cutting through the. So in parts there is a natural groove and later it is not. So when I'm cutting through the tissue, it is close to the adenoma. That's why there is some charring.
See,
As we deepen the incision, like you see in this area, there is no charring because the distance was correct.
Yeah, I'm wondering whether it is because of the MOSES technology, because we usually do not see this type of charring while we are using the normal slimline.
Correct, sir. Correct. Correct. But I think it's because we are close to that and through the tissue.
That is the reason why it is hemostatic.
Probably, sir. That same thing for all the hemostatic lasers. So if we see in this area, you see some transverse fibers.
Yeah.
Those are the fibers of the capsule. And fluffy thing is the adenoma. So whatever is silvery and transverse is the capsule, and whatever is fluffy is the adenoma. As we deepen this incision, we come distally and we go medially as well. We go a little bit under the lobe. See, even though we would like it to be, the capsule is never round. It's always up and down. So we have to move our fiber as per the shape of the prostate. Wherever required, we have to go deep. Wherever required, we have to be superficial. Like in this area, it's going deep, so I'll have to go deeper. Now I'm almost at the level of bladder neck. So in case we would have not been able to see orifice earlier, I would have checked for orifice at this point. Now I know it is far. Is the vision a little better than before or is it still the same, sir?
It is better.
So we'll make the other side incision now. 7 o'clock incision. We rotate the scope. We have to use the rotating movement of the scope. That's why we need this inner rotating inner sheath in HoLEP. So we are making the 7 o'clock incision. See, only in this area the charring is more, where the bulk of adenoma is there and the plane is not very clear. Till we have seen the capsule in most of our area, it should be okay. Here we are cutting through the adenoma, that's why this thing is there. And this will create some trouble during the lateral enucleation also. Air conditioning, I think, needs to be better.
This charring reminds us of thulium fiber laser.
I know where I know where you're getting, sir. But at the end of the procedure, we have to see how much charring is there. Right now, it's through the fossa, through the adenoma. That's why I think it's there. So with any laser, when we are closer to the tissue, there will be charring, sir. And that is the problem with TFL. In TFL, the depth of penetration of laser is less. So you have to be very close to the tissue to for it to work. That is why the charring is more.
That creates difficulty in identifying capsule.
Correct, sir. Correct. Absolutely. You will not see fibers like this in TFL. Now, many a times, if the lobe is not getting lifted, I can lift it slightly and then cut these fibers. These are the fibers supposed to be divided, sir. But laterally, I'm not reaching that margin where I'm supposed to. So any doubt, we go to the defined area. We go back to the place where we have started the incision. And from there, we come back to this area. Once we have reached the capsule, we have to stay almost parallel to the capsule. Of course, if the gland is going under, we have to go to that.
What do you mean by parallel to the capsule?
Sir, I'll just show you. For example, in this area, near the bladder neck, if I go deep, I will cause undermining. If I keep this direction. So we have to keep parallel to the capsule like this.
Okay.
The direction of the fiber. Of course, you have to change the angle as required, but most of the part you have to be parallel. Once you have reached the capsule. So, earlier it was straight incision, now I am making sort of a J shape. I am going under and like this, trying to reach the correct depth. No. So Dr. Aveen asked me a role of blunt dissection. There is no role of blunt dissection in HoLEP. Now I am doing hemostasis using the right pedal. There are two ways of doing it. One is by using this pedal, or like most of our older machines have single pedal. So you either have to decrease the setting or you can just defocus. Hemostasis with laser always take a little longer compared to TUR or electrocautery. So you have to be patient. Sometimes you may not be able to do also. So don't go on trying to do it. If you are not able to do for some time, move to the other place. By the time you come back later, it would have stopped, or you will have better exposure to do the hemostasis.
I think if you cut more, it will stop.
Agreed, sir. Agreed. So this is where the aiming beam helps us. That's why I like to keep it on also, so that you can pinpoint on the bleeder and then do it. Actually, the vessel was running like this, so I wanted to do it right away. As it is, as you go on enucleating, the plane gets better and the bleeding would be very less by the end. Every time we go there, the bleeding will be more. So now again, same thing on right side. Start from bladder neck, work almost parallel to capsule, go deeper where required and come under the lobe, trying to join these. So these are the fibers you are supposed to divide.
While you are here, how do you know that you are not going subtrigonal?
Subtrigonal will be only near the bladder neck. So when I am coming there, I will be more careful. That's why I make this J-shape incision whenever in doubt. Near the bladder neck, I would come from inside the bladder neck to under the lobe or to more distal part. And you have to be more careful as you go more and more proximally. So HoLEP, we have to be patient, sir. If we go on just cutting, then definitely we can go subtrigonal. And all of us do it initially, but later on we learn how to avoid it. So we also get a feel from the tissue whether it is going away or not, sir. And that feel is important. Now this is the incision on one side, this is the other side. This is where it is getting connected. I think little more I will do this. Okay. So that's the median lobe. These are the fibers we are supposed to divide. Can you see? We made incisions, we came medially till here, then here. This was the point which was bleeding. We have better exposure, so we can do a better hemostasis now.
Yeah.
At least it's supposed to be better. Let's see.
And now there is no charring.
Yeah, when the distance is correct, charring is not there. Only when you are very close to the adenoma, charring will be there. Okay. Just like TURP, wherever you have cut or enucleated, better to do hemostasis at that point only. At least try. He is moving. Can you tell him not to move? So we go on dividing these fibers. I hope you can appreciate, sir. We are
Very
reaching
nice.
the bladder neck. So the trick to prevent subtrigonal incision is by making this J-shape incision. If in this area I would have gone deeper, I would have definitely gone under the trigon. So now near the bladder neck, mucosal attachments. Now there is always a tendency to go inside the bladder and fire at this point. One should avoid that. Just fire near the capsule only. The fibers would get separated and then you can just push it away. So our median lobe is gone. It's right here, quite a big one. We confirm hemostasis. If required, we do some hemostasis. See, all that charred area is not seen now, sir. We see only capsule. So again we come back to Veru, and now we make our distal limit anteriorly because we don't have a natural marking there. We come to Veru, we rotate. We rotate the scope, and the fiber should be a little distal or proximal in the fossa. So we make an incision here. When we start making this incision, always the vision will be a little poorer. But as you reach the capsule, generally the vision clears up. Just stop for a second.
Again, how do you know when you reach the capsule?
Sir, one trick is that the vision would become clearer, as is happening here also. And second thing is you will see those transverse fibers again of the capsule. I'll just show you. In this case, there is some tissue anteriorly. That's why the capsule is a little deeper. So can you see this, sir? This silvery,
Yeah.
that is the capsule. So that is the capsule and this is the adenoma. I hope it is clear, sir.
Okay.
And if you can see the direction of my scope, cameraman, can you show? You will realize how much anteriorly we have gone already.
Yeah, right
Can you see how much I am having to bend it? So it is quite deep. Now we make the 12 o'clock incision from the bladder neck to the, थोड़ा पीछे कर लो, hand movement दिखाते रहना, bladder neck to this point, and we stop here. So this is the advantage of making this incision. We know where to stop and in turn not injure the sphincter. Then we deepen this incision. After reaching the capsule, we make a zigzag sort of motion here. The purpose of this zigzag motion is to make a trough anteriorly. We have a nice trough in the floor because of the median lobe enucleation. We make another trough anteriorly so that the movement of the fluid in the fossa is very nice during the procedure. Also, it partly enucleates the lateral lobe. Yeah, that's what. So this marking which we made a little proximal in the fossa. That is one way to prevent the bulk of sphincter. Next thing to prevent sphincter injury is what we will do next. I will show you. Okay. So we made a trough anteriorly. Can you appreciate, sir?
Yes.
Okay. Now we come back to the verumontanum. We make our early apical release. By doing early apical release, we release the adenoma from the sphincter, which is here. Okay, sir. So we.
Sir, एक second wait कर सकते हो sir?
Sure.
Just to raw light में करके देखो.
Sure, sure. Please give me a moment, sir. They are making some changes to the electrical connections. सिस्टर बीच बीच में ना जेली लगाते रहिएगा यहाँ पे. स्फिंक्टर हॉर्सशू है तो बल किधर है एंटीरियरली, तो हमने थोड़ा सा आगे जाके इंसिजन दिया. एक तो हमने रोटेट किया, ऊपर से फाइबर थोड़ा आगे किया, तो उसमें आपको सो वो अभी यू हैव टू कट अलोंग द कंटूर. आई शो यू. अभी करेंगे ना. वाइड बैलेंस फिर से करने का जरूरत है क्या? नहीं ना. So now we do the apical release. So we start from here, 6 o'clock position. वो नहीं होगा, I knows the problem. So we move along the contour of the prostate, somewhere between the prostate sphincter and adenoma. So we go from 6 o'clock to 3 o'clock position on one side, and then from 12 o'clock to 3 o'clock. This is our marking from here to that point along the contour of prostate. 12 to 3. This is the last connection. Can you see, sir? This is the sphincter part and this is the adenoma. So we deepen this a little further, taking out little more tissue from here.
This is the part where we always falter.
Yes, yes, sir. This is where we have to be careful.
Meeting the two incisions together.
Yes. Yes, yes, yes. So we have to be mindful where it is, and we can always come back and see a little. So this part is just like how we do for the apex in TOR. We get behind the sphincter and we resect. In this case, we get behind the sphincter and we enucleate. So now same incision we give on the other side. We move along the contour from 6 o'clock to 9 o'clock position, and then from 12 o'clock to 9 o'clock position. Now it is connected. So now our apex is released from the sphincter all around. So this is called as early apical release. Now we go about enucleating the lateral lobes. Same incision we deepen. Same incision we deepen and we separate we reach the capsule and we go about enucleating the whole thing. So I like to see a halo around the beam. That is the correct distance for me in HoLEP. When I see a silvery halo around the beam, I know that I am at the right distance. If I go too close, I will get charring. If I stay too far away, it won't enucleate. So for me, the correct distance is exactly this when I see a halo or silvery halo around the beam of the laser. So again, we go from below above. This is the capsule, this is the adenoma. पानी चल रहा है, पानी ख़त्म हो गया, चेंज कर दीजिए। सिस्टर कोशिश कीजिएगा एयर नहीं जाए। So again we deepen this till the capsule. So wherever we cut through the tissue or we go very close, we might see some charring, but definitely it is much less compared to some other lasers. So just go on lifting. Now we'll come from above below. If we go on cutting only in one plane, then sometimes it becomes difficult to connect the two planes, because you might be in two different planes near the capsule. If we see some tissue, we have to go deeper till the capsule, wherever we see tissue. Sister jelly डालिए please. So any doubt, go to the defined area and come to the undefined area. This is the defined area. We'll start from here and come back in the fossa. See, now we have better identification of capsule. Again, same thing. I hope you can appreciate the capsule and adenoma separately, sir. There will be places where there will be sticky adenomas and you might have to cut through them near the capsule. Ideally, they should all separate out very easily with laser, but sometimes they won't and you might have to cut through the adenomas also. And you can just fulgurate it right there. I don't know if you are getting the hand movements also, sir. Because hand movements are very important, I feel.
No, we are not seeing it.
Sister, यहाँ पे कुछ डालेंगे ये पानी आ रहा है मेरे ऊपर. Hand movement दिखा दीजिए.
Switch on. Yes.
Because hand movements are important, I feel. They'll have to give us PIP. Touch ना हो ये देख लेना, ठीक है? नहीं, इनको कैमरा टच ना हो. क्या लगाना है? हाँ लगा दो. यहाँ जेली डाल दीजिए थोड़ा. So somewhere there is a mismatch of plane. We have to join these two planes. I have to see why that is happening. That can happen. Yeah. I've gone a little more distally in this area behind the sphincter, so I'll have to connect these two planes. We have to see how best we can do it. So ideally we should just follow the capsule and that will show us the right depth and everything. And eventually they would connect. So coming more proximally, because there is some tissue here which is preventing me to connect these two. But I have to be mindful of the position of the sphincter. I should not come too proximally. Let's see. Okay. So I'm taking this tissue also along now because this is what is preventing me from joining these two planes. So I am doing some correction here behind the sphincter, taking this tissue also along.
Tanuj?
Yes, sir.
Yeah. So there are very senior doctors
Yes.
sitting here.
Yes, sir. Yes, sir.
Some postgraduate trainees are also here.
Yes.
And your show is being streamed on YouTube and Facebook.
Okay.
Yeah. We are absolutely in awe. I mean, mesmerized. As I don't do the surgery, but I'm still, enjoying it.
There is a little bit of challenge in this case because this tissue is coming right till the sphincter. So I'm just trying to take it also. Otherwise, I could have just gone in this plane, but then that would not have been a very good enucleation.
So that's like that we can appreciate that sometimes maybe it can become challenging to identify the correct planes and maybe to remain in the same plane.
So I am going sometimes from below above, then from above below, so that I can reach the right place and then enucleate this entire lobe.
Okay.
You have to be careful in this area.
So what do you feel for a beginner, just a trainee,
Yes.
what size of prostate he should start doing?
I think best is to start with a medium-sized prostate. Don't go for too big or too small a prostate. Because if you go for a very big prostate, then you'll get lost in planes. If you go for a too small prostate, they are generally those recurrent prostatitis ones with too many sticky nodules, then they trouble you. So best is to go for medium-sized, say 50 to or 40 to 70 cc prostate. I feel is the best for beginner. That also what I recommend is that initially all your TORPs you start doing bladder neck incisions with laser. 5 cases you do that, then 5 more cases you do median lobe enucleation. You will understand the plane and everything. इनको ना move कर रहे हैं, तो बोलिए move ना करें. Patient को बोलिए move ना करें. So that is the best way to understand the plane and move on to a complete HoLEP. So it takes about 20 cases. The learning curve is of about 20 cases to understand the correct way of doing the HoLEP, and it takes about 50 cases to master the technique. Also, one should not, limit the indication. Don't wait that only I will do when a 100-gram prostate comes, because they are not very common. And if you don't do regularly, you will not understand the technique. So, and it's not, there are so many patients on antiplatelets now, and HoLEP is the surgery recommended for these patients. So you always have patients for these. So one should start doing, as I said, laser BNI for your routine TURPs, then median lobe enucleations, and then the complete enucleation. That is, I feel that's the best way one can go. Of course, mentorship is very important in HoLEP. Initially, it is better to have some mentorship and some hand-holding.
I think that's a great point. You should start doing BNIs and then maybe medial lobe integration and then...
Because most of us anyways do a BNI before TURP. So we can do the same thing with the laser. And actually, that TURP will also be better because you would have gone to a deeper plane compared to your knife, hot knife.
Okay.
कुछ change कर रहे हैं क्या? क्या हो रहा है? One more thing, sir, this camera should be it should allow us more play in HoLEP because you have to rotate the scope every time. Like right now with this particular camera, it is a bit tight.
Okay.
So the camera should allow us more play so that there are no jerks when we are doing the enucleation. If there are jerks, the plane changes. So again, defined to undefined. You should always be able to come back to the urethra and see where you are and then course correct. So that is why en bloc should be attempted by experts only, because in en bloc you will not always be able to come back to urethra during the enucleation. I mean to the midline. As far as possible, we should avoid, going through the prostate. Just keep it at a little distance, let it separate itself. You'll reach the capsule, there will be less charring, and of course, patience is required. I think I would agree that there is a little more charring than what we see usually in a HoLEP. आप एक बार यूजुअल सेटिंग कीजिए, 2 जूल्स करते हैं ना आप, कीजिए देखते हैं, स्टैंड बाय करके होगा. आई एम जस्ट इंक्रीजिंग द सेटिंग टू देयर यूजुअल सेटिंग व्हाट दे रेकमेंड सर, टू सी इफ वी गेट समथिंग बेटर. हाँ.
You mean the laser settings, right?
Yeah, laser setting. What is recommended by the company.
Okay, but you usually use the lower settings.
I use lower settings, sir. 1.2 or 1.5 joules and 50 hertz is my usual setting. So you might feel I'm cutting little bit through the tissue here, but I'll come back and see this area after this lobe is enucleated, so that if anything more is required, we'll do it. I'm just trying to reach the common point of both the planes that I've created so that I can enucleate this nicely. So again, okay, again from defined to undefined. Just lift the lobe, identify the plane and cut. So we are not pushing here, we are just lifting the lobe with the beak of the scope.
I think Amrin here got the answer, because I mean he was asking whether we can lift the lobes with the peak of the.
Yes, yes, definitely we can lift. And what happens is when you stick to capsule, you see even more, when we stick to capsule, we are doing more like the en bloc technique. So we end up taking out more and more tissue. Like this tissue was earlier remaining here.
Now the planes
Because
are pretty
this is,
clear.
yes.
Yeah.
And if you remember, this is the area we were seeing charring during our bladder neck incision.
Right.
Because there was adenoma here. It was preventing us to go to the capsule properly.
Fantastic.
Of course, as we go more proximally, we have to be careful about the undermining. So as we reach near the bladder neck, again we'll switch to the J maneuver. So again, lift and cut. Yeah. So see, this is our plane from above below, sir. Here, right here. And this is the one from below above. There is some tissue here which we'll tackle after this goes, because this was holding us from doing this. So I will do that part after enucleation of this lobe. So I'll just connect these two now nicely, staying on the capsule and lifting the adenoma. So these are the difficulties one can face. You might feel you're lost in planes. Just go again and again to the whatever you have defined, and from the defined area come to the undefined area. Then you will reach the right place.
side we appreciate that prostate being nicely enucleated, perfect planes.
That is the beauty of this procedure. So when we are right on the capsule and we recall our open prostatectomy days, and definitely the best results are with enucleation, sir. Even TURP, I mean, we are trying to reach what we were doing with open prostatectomy. And even in open prostatectomy, the incidence of stress incontinence was more, but it settles. And same thing with the HoLEP. Now again near the bladder neck, what I was telling, the J-shape sort of maneuver, so that we prevent undermining. Many a times tissue would really dip down near the bladder neck, and one has to scoop it out also at times. Some mucosal attachments here. Now again. Again parallel to the capsule. We should not, direction should not be this, either it should be parallel, or what some people do is they reverse the scope and then they enucleate again to prevent the undermining. Either ways.
I hope Amrin is learning these tricks.
He is right next to me, sir.
Okay.
And in my ear he is asking me a lot of questions otherwise also.
Okay.
So that's the left lateral lobe. We look at the fossa. First we do hemostasis if whatever is required. If there is a bleeding somewhere. Generally we would just see some vessels like this. Instead of, yeah, there we need to do some hemostasis. Again we are using the hemostatic settings. The pedal is different. Now if I look from here, it appears that yes, everything is gone, but I know that there is something remaining near the sphincter. See, this is the veru, sir. This is beyond the beyond the veru, whatever this tissue. This part I don't want to touch because this is near the bulk of sphincter. This part we will, there are two options. One, we can enucleate it. Second, we can just sort of blast it or vaporize it. So we'll do a little bit of both. Because at the end, when we are trying to finish this part, we realize that it was not much tissue.
Do you change energy setting while you are working near Veru?
In my routine practice, yes, sir. So my routine practice, I do 1.2 joules and 50 hertz.
Okay.
So I don't increase the setting at all most of the times, unless it's a very, very big prostate. Anything more than 150 cc, I would do with the 1.5 joule and 50 hertz to save some time. 1.5 is also safe. And with this Moses, I think even 2 should be okay here. Again, getting into the right plane, just scooping out. Yeah.
Transmission is just perfect. We can see your hand movements, I mean, very clearly. We can very
sir.
clearly see the endo view.
I think hand movements are very important in HoLEP, sir. Because just by seeing endo view, one may not understand what exactly I am doing. By seeing the hand movement, at least you know when I am rotating the scope, how I am doing it. And the fact that we are not pushing anything here. That's the real advantage of HoLEP over bipolar or mechanical enucleation of prostate. there it goes. Once it completely separated, it should go into the fossa. If it is not going, that means it is still attached somewhere. So this is the fossa of the left side, sir. Seems okay. This I can do, but it will be only cosmetic.
Right. Hardly any tissue there.
Yeah, and this I will not touch. So now we'll go to the right side. This one we can do something, but again it will be more of cosmetic. Actually, this flickering does cause little bit of vision. I mean, yeah, but I think that cannot be changed.
Anyway, we can reduce this flickering.
I don't know. I think after this case, they will check the camera if they can change the camera or something. But I think the line has to be different or something.
Yeah. I think power supply has to be changed.
Yeah. Mostly these both are in the same line or in the same UPS line, something. Because as it is in a HoLEP, we have to continuously stare over on the screen. So this increases that even further. One of the ergonomic points about HoLEP is always keep blinking your eyes, otherwise you can develop dry eyes because you're continuously operating and looking at the screen. And preferably the screen should be right opposite, near the head end of the patient, so that there is less strain on your neck also. So in our OT we have here also you have a pendant mounted monitor. We have a pendant mounted monitor, so that can be kept right where the screen is right now. So that is it makes it less tiring. Okay, so I think left lobe is done, floor is done. Now we'll go for the right lobe. We already have made our mark, so we'll just deepen the same thing. Go from below above, going behind the sphincter a bit. After a point, HoLEP becomes boring because it's the same thing you are seeing. So we are just lifting from below above, from the fossa towards the lateral wall, from the floor towards the lateral wall. And from below above, can you appreciate this, sir? This much is lifted.
Yes.
This is the floor, this is the adenoma. Now we'll come from above below.
We are seeing the video in PIP.
Yes.
Let us come back.
Please do the endo view in bigger screen. PIP should be hand movements.
It's okay now.
I'll show again what I have done so far on right side. This is the veru, this is the sphincter. I have lifted the adenoma from here till here, almost mid gland. And now even little more display. Can you appreciate this part, sir? This is the floor, this is the adenoma. Now again from above below.
So this side we can appreciate better planes, no? Compared to the right side.
Yes, sir. So the challenge on this side also will be again near the sphincter, because it is this prostate is going beyond the veru.
Tanuj,
Yes, sir.
most of the prostate which are 100 grams or more
Yes, sir.
will hang beyond veru.
Yes, sir.
So how to get into the plane near the veru, because it becomes difficult
So
while we are working near the veru.
I think same thing what we did for the left side. Just go from above below, then below above. If you're not able to reach, just make a plane there, finish it. Then after that we can, like in TURP,
Okay.
we do the apical part later. You can do a apical part later also in HoLEP. That would also decrease the stress over the stretch over the sphincter during the procedure, actually. Otherwise, if you are able to get behind the sphincter and reach the right plane initially only, nothing like that.
Yeah, you will have to find a new plane while, since you are cutting through the prostate.
Yes.
It takes time to
Yes.
get into new plane again.
Yes, yes. So what I have seen in the beginning, funny chalaiye please, everyone tries to stay more superficial,
Yeah.
and that leads to more bleeding and recurrent loss of plane. So that should be avoided. One can be bold, and the trick to do that is to start the BNI and median lobe enucleation so that you know what the correct plane is. And even in HoLEP, even if there is a perforation, it's generally a very superficial perforation, sir. One should not be scared of it. Even if you see some fat, it will not lead to anything.
Yeah, it's entirely forgiving
Yes, sir.
as far as HoLEP
Yes,
is
sir.
concerned. Even
Yes,
if you do a capsular perforation,
Yes.
it's not going to
Like
trouble you.
in this area, it is thin right now.
Yeah, yeah.
So I will correct my plane, but I am not too much worried about it. That's why you see me cutting here through the tissue. I don't want to be this deep.
Yeah.
So we don't have to go in absolute same direction all the time. We have to change as per the fossa and the anatomy of the lobe.
True.
Till the plane is correct, bleeding will be less, and that is another sign how you know that you are in the right plane. Now we come back. So this is the sphincter area. We have enucleated from here till here and from here till here. So we connect these two now. So on this side we will not have to do that enucleation or fulguration.
Is there any increased chance of stricture?
Stricture and increased chance of stricture in laser? No. The reason for stricture in HoLEP is, one, if you have passed the scope through a tight urethra. Two, if there is too much of traction. Third, if there is less lubrication. These are the reasons why a stricture would help. Or fourth, if it's a prolonged procedure. So that is why now in more than 300 cc prostate, role of robotic prostatectomy is coming in. Because that is something that would take a longer time. So you can do a urethra sparing procedure.
Stricture in HoLEP is same as in TURP because the factors are same.
Yes, sir. No, sir, but no current, no, sir. There is no current leakage, so that is one factor which is different. Especially bipolar, you know that there are so
Yeah.
many reports. Bipolar, whatever they supplied in India led to some strictures. So again, this is the area where there can be subtrigonal incision. So we come from bladder neck till and go under the lobe. Bladder neck and beyond. And these can be a gradual cuts, which can be a little superficial, so that we don't go too deep. Okay. Now, this is what remains. We try to go under if possible. Not possible, we come from here on. Yeah. This needs to be taken out. Under the lobe and divide the fibers.
फिर कोशिश करता हूँ. I'll try again. I'll give a more.
Also maintaining this distance is important, sir. If we go very close to the lobe, we can go in different planes, we can go deeper, more superficial. Just keeping it away, letting the laser beam split the fibers is the best way to go about enucleation.
ज़्यादा deep रहे क्या सुहास? ठीक है.
I hope the vision is fine, sir.
Yeah, it's okay.
Now this is the area where you can go subtrigonal.
Yeah.
So try not to go too deep. Best thing is to come from bladder neck to this area. And in a gradual way, be little more superficial, so that we leave some tissue here. Better to be patient here, not to be in haste, otherwise you can really go deep. Again, last few fibers, and there goes the right lateral lobe. So this is the verruca, sir. You can see the sphincter, nice fossa all around. We'll see if we need to do some hemostasis.
Beautifully done.
Thank you, sir. Left side took a little more time. Right side, I think, not much time. There's not much bleeding. Another sign that we are in the right plane. Not much of a bleeding. So it's always better to ensure that hemostasis is good before you start morcellation, because the vision has to be really good for morcellation. That decreases the chances of causing an injury. It's a very wide bladder neck. Okay. So these are our lobes, quite big. This is 1, 2, and I think the third one is behind these two somewhere there. 3. All 3 are big lobes. So reasonably big size prostate, sir. Should I start with the morcellation if there are no comments, or stand by please? So I have a very nice assistant who was careful that it should be standby before we take out the laser. And it's important to save your instruments. If by accidentally you fire with the laser inside, then the scope is gone. Yeah. Sure. हाँ मुझे मालूम है. चलो लाइए सिस्टम ऑसिलेटर दीजिए. इसमें इनर शीट निकालने का ज़रूरत है क्या? नहीं ना, निकालना पड़ेगा ना. लाइट स्टैंड बाय प्लीज. इनर शीट निकालना पड़ेगा ऐसे ही. निकालिए जरा, ये निकल नहीं रहा. यहाँ ऐसे. ओके. तो इसमें आप इनफ्लो किस में कनेक्ट करेंगे? उसमें
लाइट केबल चेंज करना.
ओके. So we are just connecting the morcelloscope. This is the Wolf morcelloscope. The length is shorter than the Karl Storz morcelloscope. एक ही मुझे बहुत है सिस्टर.
Yeah.
ज़रूरत पड़ेगा तो दूसरा.
Tell us more about this morcellations.
So currently I have taken the Wolf morcelloscope. For good morcellation, the bladder should be full. My attendant should be careful that the bladder is always full. She'll have to check the bladder again and again. I'm just connecting the light and camera. As I said earlier, one should make sure that the hemostasis is good. Otherwise, that takes up a lot of light. पानी चलाइए please. पानी बंद मत रखो इतनी देर ना, clots बन जाते हैं. Saline on please. Saline on sister. Both bottles on. So I generally attach only, दोनों चलाइए. I generally attach 2 bottles. Light on है. Light on कीजिए, Storz वाला. White button, yes. On नहीं, on नहीं, अभी कीजिए. एक बार दबाइए, long press नहीं, short press, yes. Oh sister, ये तो white balance फिर से करना पड़ेगा. वाइट बैलेंस बाहर निकाल के करना पड़ेगा ना. वो हो जाएगा इसमें? नहीं, बाहर निकाल के हो जाएगा, बिकॉज दूसरा यूज़ होगा ना. कीजिए वाइट बैलेंस. करिए. नहीं होगा बिकॉज वो लाइट सोर्स दूसरा है, मुझे मालूम है. ओलंपस में So some people like to use 2 TOR sets. I don't use 2 TOR sets or any pressure. I use 1 TOR set, but I keep 2 bottles on. All the outlets are closed so that the bladder fills nicely. That prevents the risk of bladder injury during morcellation. This is one adenoma. That's the second. The third one is behind this. So sister दे दीजिए please. थोड़ा table height बढ़ा दीजिए. And sister, I want you to keep checking the bladder, okay? So there is a separate pedal for morcellation. We are using the luminous Versa cut today. When you press the pedal half, it sucks. When you press it completely, it sucks and morcellate both. So half pedal should be pressed to hold the adenoma, then we should come to the center of bladder and then start modulating. So I'll just half press and try to catch it. Now we come to center of bladder and we start modulating. This is bladder pressure, please. Bladder pressure check कर लीजिए. इसमें छेद कर दीजिए बॉटल में, है ना, दूसरे वाले में भी है ब्लैडर. उधर से आ जाइए, आपको कंफर्टेबल होना जरूरी है. Is this a new blade? इसको ना आप स्पीड को मीडियम कर दीजिए. स्पीड ऑफ मॉर्सुलेशन, हाँ मीडियम. यस. So we get under the lobe. This is the fossa only. Modulation better to be done in the bladder as a last resort in the fossa. Get under the lobe, catch the lobe and come to center and then start modulation. Any doubt, just rotate and see. If the whole thing is rotating, means you are catching the adenoma only and not the bladder wall. हो नहीं रहा भैया. Some issue. Okay. तीसरा bladder है ना. So the assistant should keep checking the bladder that it is distended. One thing is that many a times when the tissue is too hard, it will not be cutting, but it is still sucking out the water. So the bladder can collapse, and that is when you need to be more careful because you can cause injury. So this is a good modulator, but I think Boston should do some innovation in modulator now. It's been many years since then the model is same. So it is cutting, but it is cutting only small pieces. So again, we'll have to be a little patient here.
What are the options for modulators?
So a lot of options nowadays.
Okay.
So I will just classify them in two ways. One is the to and fro cutting type like this one. The other one is the oscillating type of modulators. In oscillating type there is there is Piranha from Wolf, then there is one from Karl Storz, there's from Biorad, Quanta, and one more called Solimo. So I think Luminous should also look at oscillating type of modulators now, because the shape of that cup holds the prostate very nicely. Again, it's a large fossa, so the adenoma keeps coming back into the fossa as we modulate. AC on है, ये थोड़ा फॉगिंग हो रहा है ना मॉइस्चर की वजह से. हाँ, चिल कर दीजिए. So I'll do because it's not getting modulated out very easily. So I will just reverse this and do what is called as inverse modulation. How that helps is that even if it bounces off the modulator, it comes back towards it, the adenoma. Let's see. Yeah.
Tanuj, I feel this is the most unpredictable part of entire operation.
True, sir. True. And in very large prostate, sometimes you have to stage also.
Yeah.
So there are certain, I mean, what do you say? troubleshooting about musculation. First thing is that hemostasis should be good, the vision should be good. Second is if it is not musculating, you can do this, what I'm doing right now, reverse musculation in the bladder. If it is still not musculating, you can break it into the fossa and try to musculate. And if it is still not happening, then it is better to stage it, because you just put irrigation for a day, next day you come in, the adenoma is much softer and it musculates out easily.
ये थोड़ा ढीला छोड़िए, ये नहीं लगाइए इसका, मत लगाइए, अब मेरे हाथ पे आ गया, ऐसे पकड़
This
लेते हैं.
problem of catching and going, that is more commonly seen with this versa cuts and this to and fro movement.
Yes, sir.
Newer one which has come, they hold tissue nicely.
Yes, sir. And I feel that's the reason is the shape of the cut in the musculator.
Yeah.
This is a square or rectangular shape cut. That is an oval cut.
Oval chop.
That aligns better with the adenoma and catches it nicely and cuts also bigger pieces. So versa cut, when it works very nicely. When it doesn't, then it troubles you a bit.
It will make your life hell sort of thing.
Yes, because at the end of enucleation you will be a bit tired, and so it's also a good idea to have a team. You know, if it's been a big prostate, one person has done the enucleation, the other person can come and do the musculation. He will do a better job and a faster job.
That is the reason we have taught our DNV student how to do morcellation first.
Correct, sir. Correct. That's the way to go. And anyways, that is what everyone is more scared of.
Yeah.
So it's always better to stop in between, let the bladder to fill and then cut again. You see, what we were having difficulty in the usual way of musculation, but with inverse, it is working better. There will be a certain aspect of prostate which will allow you to grab it better. So we just have to try and find that aspect so that it holds it nicely and then starts musculating. The rougher surface is always better.
The problem comes in the last when the
Correct.
leftover
Nodules
tissues
there.
are round.
Yes, sir. Yes, sir.
Then it fails to hold and cut.
Yes, sir. Sometimes you have to use cautery also for that.
Yeah.
Now, I don't know if it's bladder mucosa or not, so I just rotate and see. It seems to be moving, still I will just leave it and check again. Yeah, it was adenoma only. Just a bladder, hai na? So adenoma keeps coming back to you. है ना? फील हो रहा है ब्लैडर? कभी भी आपको लगे कि नहीं है तो आप जोर से बता देना मुझे, ठीक है? Are you sure this is a new blade? Are you sure this is a new blade? Let's see. Again, always better to stop, let the bladder fill and then musculate again. Now when it is not cutting, it is still sucking in the bladder, so bladder would collapse. But we'll check and do it. After catching the lobe, in this technique also better to come back to the center of bladder so that you are away from all the walls of bladder and then oscillate. Bladder is there, Nasta? Bladder है? I think while I'm oscillating, if you want to go ahead with the lecture, you can do it, sir. So this will take a bit of a time. Any doubt, again rotate and see, and then oscillate. this is what I mean. In the end, you will have these nodules which can be troublesome. So best is to bring them to the fossa and then morcellate. Again, bring it to the fossa. पानी दोनों चला दीजिएगा. The water is finished. We are just waiting for them to change the bottles. Saline is finished. चला गया. दोनों चला दीजिए. दूसरा भी बदल दीजिएगा. एक बार दूसरा ब्लेड ले लीजिए सिस्टर, चेंज करके देखते हैं. स्टेराइल है ना दूसरा भी? वन मिनट. अब स्टेराइल ही रहने दो, ज़रूरत लगेगा तो चेंज करेंगे.
अभी आप ब्लैडर पे आ जाइए सिस्टर, मैं बोलता हूँ अगर चेंज करना तो ब्लैडर पे आ जाइए, ब्लैडर देखते रहिए क्योंकि ये ब्लैडर खाली हो रहा है। है पैडल आगे कीजिए प्लीज, स्लिप कर लिया मैंने। Can someone see my phone, please? So any questions from the auditorium? Are we still connected?
Yeah, we are connected and we are still watching you diligently going through the motions.
It's more fibrous, this gland, sir. I thought of changing the blade, but then I realized it's not the blade's fault. The prostate consistency is such. So instead of doing it in bladder, I'm doing most of the modulation in fossa, so that even if it bounces, it comes back. And in the fossa, you can chase also. Only thing is the vision should be good. The vision in fossa generally will be little poorer than the, depending on the bleeding.
The vision is good.
Yeah, currently it's fine, and so mostly I'll try to finish in the entire modulation in fossa itself. So even though I'm picking up from inside the bladder, I'm bringing them to fossa and modulating. And we have managed to make it smaller. Hopefully we'll be able to finish it also. Only thing is, as I said, when it's not cutting, it is still sucking. So we have to be careful. The bladder can become empty. The assistant has to be very careful. 10 minutes. This is what Srinivas sir was talking about, these nodules in the end. Sometimes you even have to cut with cautery. And this is when you can actually cause a bladder injury, more chances. So better to catch, come to fossa and then musculate. Sister, bladder is there, no? Now this is, can you just release the, it's adenoma or, I got hold of the fossa, I released it. Some small nodules are there. I think one is a big one, we better we do it.
You can use tripong.
So we can use, but if it doesn't come out, then it becomes frustrating. So before I take out the oscillator, I want to give all the best chance. Once we take it out, then we'll take it out somehow.
Problem is when it is not cutting,
Yeah.
it is sucking more.
Yes, and the bladder
chances
can
of getting,
collapse. Yes.
empty bladder is pretty high.
Yes. You are right. Now they are small only. I think there is one piece which needs to be morcellated out. Rest all can come in wash also, I think. I'll just wash and see.
Per se will increase the bleeding sort of thing, because it will open up whatever bleeding which has been controlled till now.
With this one you are telling, sir? Elix?
Yeah, Elix, yeah.
Yeah, but
that's the only thing.
yeah, but generally, I mean, all of us have our own protocols, I think. So, in my experience, even though we say that, yes, kidney triply, sister, that can catch with forceps, some of these slippery nodules are difficult to catch even with forceps. I think most of them have come out in the wash.
Actually, catching with forceps, apart from pulling it out,
Yes,
it
sir.
causes the smooth surface to become rough.
Yeah, that
so
is
that
there.
it can subsequently be
That is
tackled.
there. That is there. I think only one piece is left. Most of it has come out. We'll take this also out. Yeah. All of them have come out, I think. We'll just check. That's the bladder. There doesn't seem to be there anything in the bladder.
Fossa, we have to see.
Just check the fossa. There is a small thing there. This is also there. There's a little bigger piece there.
This needs to be morcellated.
Yeah, this will be morcellated. So that's why it's always a good idea to check the fossa towards the end. This can be morcellated out. Morcellator still. Morcellator. नहीं चलना तो सही है। वो दूसरा डॉक्टर श्रीनिवास यूज़ कर लेंगे ना, ये दो ही लाए होंगे मोस्टली। थोड़ा पानी का हाइट बढ़ा दीजिए, बहुत अच्छा से फिल नहीं हो रहा है। just switch off the inlet so that if there's something that should settle in the floor. Not seeing anything, but we will check. I think there is one small nodule which is running over. Yeah, here it is. Better to be sure. Yeah, it's all near the bladder neck. Small, small, they will come out. Let's see. Kidney test. Okay. All this, yeah. Again, huh? Check again. Forceps है PCNL forceps. This one I think we'll have to pull out with forceps. That's the last part. है forceps? नहीं तो मॉस्कुलेटर दे दो. दीजिए मॉस्कुलेटर दीजिए. थोड़ा टाइप हाँ टेबल अप कर दीजिए थोड़ा इसको पास कर दीजिए. भाग गया. Now it should come. Kidney tray. Give me inner sheath and wash, please. Inner sheath and helix. Do you have that forceps?
Tarun,
Yes, sir.
this is Dr. Sujit Sinha.
Sir.
You have almost completed your
Yes, sir.
course. So we will shift to the talk meanwhile.
Surely, sir. Surely.
Okay.
पानी
Thank you.
यहाँ पे लगा
Well
दीजिए.
done.
Thank you, sir. Thank you, sir.
Now I will request Dr. P.K. Mishra, head of the Department of Urology, AMRI Mukundapur, to please give his talk.
So, thank you very much. We have been fortunate here to have two wonderful faculties who was trying to teach us this difficult technique of doing this surgery HoLEP. If my memory does not ditch me, it's probably 1998 or 99, the HoLEP first started making its appearance in the journals. This procedure is not new. It's almost 25 years old now. And there was a lot of enthusiasm in the this procedure because if you look at the principle of prostate surgery, it's probably one of the best possible. I'll go into the detail of that, why I say so. But in spite of the fact that it is there in 25 years, it has not caught up to the extent it should have. Initially, I was thinking to my mind, because of the cost constraints, many centers are not able to afford it. And that is why probably HoLEP is not ubiquitous. But today, you will be surprised, there are many places where the machine is lying idle, underused, half-used, used in a way which is not exactly it is intended to. There are several reasons, but one of the main reasons why this has happened, what I think is my personal perception, I will tell you. If you look at if you go to the very basics, what is the objective of a BPS surgery? Why do you want to do a BPS surgery? It's probably our objective is a maximal reduction in the bladder outlet obstruction. That's our objective. Surgical objective is that. And how do you achieve it? If a procedure is achieving a maximal reduction of bladder outlet obstruction with minimal complications, and it should be suitable for the patients of high-risk patients, then probably that will be the winning procedure for this disease. So with this, if we look at the myriads of procedures that is available today for the prostate, and I have tried to classify them with the surgical objective the procedure is intended to. So if some procedures are intended to do an enucleations, and this is no new. Open prostatectomy is the first enucleative procedures, and then there is a HoLEP, there is HoLEP, there is HoLEP, there is bipolar use and bipoleps. So these are the enucleative procedures which are trying to maximally reduce the bladder outlet obstructions. Of all the procedures described for the BPS, the enucleative procedures are intended to maximally reduce the bladder outlet obstruction and hence expected to have the maximal long-term good effect. At the end of, say, a lot of years, they are likely to stand like a solid rock and probably the reoperation rate will be less. And that has been proved and documented in the literature. Even the open prostatectomy, the recurrence rate is hardly 2-3%, whereas in a TURP, the recurrence rate is as high as 10-15% in some of the series. So then next is the resective procedures, of which the TURP is the hallmark of it. And we do monopolar TURP, bipolar TURP. Also we do vaporesections with some of these laser energies. If I remember when the thulium fiber laser first came, they were trying to teach us the vaporesection procedure in which we divide the adenoma into small chips as you do in the TURP and take it out. So this is a resective procedure where the objective is not to enucleate but to resect tissues in piecemeal and remove them. And there is also vaporization procedures, of which the green light is the biggest name in it. There is also this thulium lasers, even holmium lasers as an ablative procedures has been described. So there the objective is to vaporize the tissues and not to do any resection or enucleations. Then there are incisive procedures for small, if you remember, this goes by the name of Orandi, if I am not mistaken. So there is a transurethral incision of the prostate advocated for small glands because they will cause less of bladder neck incisions, they are minimally invasive. And also with the laser energy you can do an incisive procedures. And there are coagulative procedures which are needle ablations, microwave thermotherapies, resume. So these are all procedures meant to coagulate a piece of prostate which are likely to evaporate in due course of time. And there are, of course, compression of the prostatic tissues, which Uro-lift procedures, transurethral balloon dilatation of the prostate, and even stents. So if you look at the surgical objective of the prostate surgery, there are several surgical objectives, and of which the long-term objectives will, long-term success rate will be more with enucleation. But let us look at the side effects. So if from the efficacy point of view, enucleation will be the most efficacious procedures, and compressive procedures are likely to be the least efficacious procedures. But from the safety point of view, the picture changes. So if you look at how do you judge which surgery we should accept. Probably we look into these three parameters, whether they are safe to undergo, whether they are what is their efficiencies, and whether there is cost, what is the cost factor and the availability factors. If we elaborate on these 3 points, so let's look at the safety factors first. So is it safe for a higher anesthetic risk patients, ASA grade 3 patients? What is the risk of bleeding in these procedures? That is a paramount thing to consider. Risk of bleedings, what is the transfusion rate in this procedure? What is the safety in the anticoagulated patients in these procedures? And what is the risk of Tuer syndrome in these procedures? And what is the duration of surgery? What is the size of the instrument that we are using? What is the duration of the catheterizations and the duration of the hospitalizations? And can it be done in local anesthesia? So these are some of the indicators in which we judge the safety of the procedures. So if you look at the efficacy factors, the literature judges the efficacy in the terms of reduction in the IPSS scores, improvement in the quality of life scores, improvement in the peak flow rate, and reduction in the post-void residues, and reduction in the PSA, which is a surrogate marker for the volume reductions. So, reduction in the prostate volumes after the surgery, and reduction of the recurrence and redo surgeries, and incidence of stricture and bladder neck contracture. So these are the parameters in which we judge the efficacy of the procedures. So if we look at these factors, we need to choose a procedure which is efficacious, all the same time it is safe. And it becomes, if you look among the available resources, available methods available today for us, probably HoLEP, which is very efficacious, and if done well, it's also safe. So the merit of this procedure is it can tackle large glands, and it is considered to be the size-independent prostate procedures, and it can be done in anticoagulated patients, and it can simultaneously deal with the bladder stones very easily without change of instrumentations, and with multiple medical comorbidities, it can be executed. So it seems to average surgeon's mind, after judging all these procedures available, this is probably the most ideal procedures for a BPH surgery. But unfortunately, so what is holding back? So it's 25 years on. There are multiple units of lasers are available in several hospitals, but what's holding back in becoming the number one? Even today, if you take a statistics in probably in any country, transurethral resection of prostates far exceeds in number than a HoLEP. So what is holding back? Is it the cost? Probably not today. And it's a steep learning curve to my mind, this is the thing which is holding back the prostate surgeries. So if you are a middle-aged surgeon, which is very well versed with transurethral resection of prostates, it probably becomes stiffer, because you have always done inclinations to go back to your procedure which you are very effective at, and probably for learning HoLEP, you have to unlearn the TURP procedures. If you cannot unlearn it well, then probably you cannot adapt HoLEP to your practice. So the crux of the matter remains that how do we cross the learning curve, which is very difficult. And for that, this is what came to my mind. So how do you assess the learning curve? So the first thing I want to say you is this enucleation parameters. If you look at an expert doing it, you get mesmerized, because with how minimal applications of the laser energy, they can so effectively enucleate such large glands. But when you personally start doing it, you find it very difficult. You tend to use a lot of laser energy, you tend to spend a lot of time, you lose the plane, get frustrated, get stressed. So this enucleation parameter, that is laser to the prostate ratio, how much of laser energy is used to say a gram of prostate to enucleate is an important parameters to judge your learning curve. It becomes lesser and lesser as you start crossing the learning curve. Similarly, enucleation ratio is another parameters. Enucleation efficiency, which measures the speed of your enucleations, at what time, how much time you are taking to remove 1 gram per gram of prostate tissues, and enucleation ratio, which measures the completeness of the resections. So those are important parameters of enucleations in the learning curve. Similarly, there are morcellation parameters, which is morcellation surprisingly is of course dependent on the operator. It is more dependent on the technologies. As Srinivas was just telling me, there are different morcellators available, mainly 2, and one is much superior in his experience and probably in the experience of many operators. So this is a more of a technology dependent surgeries. Of course it is operator dependent. And there are post-op parameters to judge your learning curves. That is, how frequently you are converting to TURPs, what is the catheter time, what is the hospital stay, what is the hemoglobin drop, what is the PSA decline after the procedures, and what are the flow parameters, and what are the retreatment rates. So these are all clinical post-operative parameters which, when favorable, you can assume that you have crossed the learning curve. Similarly, the complication rates, probably once you have crossed the learning curve, it becomes very less. And the stress incontinence rates, which persist after about 6 months, is definitely very, very bothersome complications, which for the patient as well as for the surgeon. It's very demoralizing complications, and that drops, takes as much as 50 cases to drops to a more acceptable level. Similarly, failure to void surprisingly can occur if you are taking a long time. The bladder is over-distended, especially during morcellation, it is over-distended, so it can go to a phase of temporary paralysis and the patients may fail to void. But out of all these parameters, probably the most practically which can be used is the parameters. How do you judge the learning curve? Is if you can capable of doing 4 consecutive cases without any complications in a successful way. So I will define what is a successful HoLEP. So successful HoLEP is both enucleation and morcellations have been done in less than 90 minutes of time without conversion up to the TURP and with a tolerable stress and difficulty. If the surgeon is stressed at the end of the surgeries, he has not crossed the learning curve. You can yourself judge that I have crossed the learning curve or not if you are capable of doing 4 cases consecutively without getting stressed in a successful time frame. So once you can achieve this parameter, there is no need of going to all these theoretical parameters. Probably you have crossed the learning curve. You yourself can judge that you are still in the learning curve or you have crossed. So with these problems, it's not working. Can I advance? No, the previous one. So so my advice, what to do for the beginners, if you are trying to learn at whatever age you are, if you learn, so first choose medium-sized glands. Don't choose small glands, don't choose too large glands. 50, 60 grams, 70 grams glands are probably the best for the HoLEP. The reason is, if it is small, then the capsule, the capsule development is poor and you are likely to perforate. And if it is too big, you are likely to lose the plane. And manipulations becomes very difficult and it takes a lot of time, it will stress you. And clinically review the unedited videos of the experienced operators. Keep on seeing it. You get a mental impressions and try to get the right kind of techniques. And ask your mentor, be in the theater itself while you're coming. So be in the theater of your mentors while they're operating so that you can see the hand movements. So just seeing the video itself does not give you the full skill. It doesn't give you so you don't try to learn it entirely from the YouTube. Be in the theater of the mentors. And take help of the mentors in the initial cases if it is possible. Fortunately, we have got mentors today in the city itself available, so you can take help of them and review your own videos so that you can understand where you have gone wrong and probably where you can correct yourselves. And the most important thing in crossing the learning curve is probably the case frequency. You need to do 2-3 cases every week to quickly learn cross the learning curve, and that's only possible if the department organizes to provide a steady flow of cases to one interested surgeon. Instead of everybody is trying their hands simultaneously, you choose one man, give them sufficient opportunities, then probably you can cross the learning curve. Thank you, friends. So this is what was my thought on why HoLEP is not catching up, and probably you can catch up with it. Thank you.
Thank you, Dr. Mishra, for giving such an enlightening talk. And I'm sure the DNB students or the MCH students who are here, they must have learned a lot from the classification of the prostate surgeries based on the technique. I think that is something they will definitely take home. And he gave very good endpoints about HoLEP, that what can be used as parameters to judge yourself and as a successful HoLEP. I think you have given very good insight, which we will take home from here. Thank you.
Thanks, sir. We are going to start the second case, and should we break for the lunch or have the second talk? I think that's better. So Tanuj ka talk kar lete and then we'll have break for the lunch. Then Dr. Srinivas will be operating, then we'll lunch then. Okay. Chalo. So I think Tanuj. Okay, fine. I mean, I couldn't see your presentation, sir. I heard the last line, and that is there should be steady flow of cases for the surgeon who is interested in that, and so that his learning curve is over and his experience in that surgery. I think that's a challenge, and we are trying to overcome that challenge, right? And at least in our hospital, we are planning to have someone who is doing only HoLEP and one surgeon who is doing only RIRS. Yeah, so maybe in future, yeah. Yeah. Somehow we have those flow of patients regularly because of the various schemes that we offer and take and right, sir. Right, sir. So, I mean, keeping in this economic aspect, keeping in this interest of the surgeon, we are trying to figure out something, and most likely we will be able to do that. Thank you, sir. And Tanuj, yeah.
Sir, I would totally agree with the subspecialty development. That is the way forward. I do urethroplasty, I do laparoscopy, but I know my junior who is picking up well. So I would now support them more to do it more, because only thing is they should stay. They should stay, and that is also in our hands as bosses.
So there are things which we learn as we grow. So, but that is what is happening in Delhi NCR also. More and more people are doing specialty. Like I know people who are doing only andrology and reconstructive, people who are doing only uro-oncology. And there are people who are more into endourology with some lab aspect. So, and many other things what sir said about the difficulties are absolutely true. One is more scared. And even for demonstration, I always feel it's better that we keep, smaller prostate so that one gets a take-home message, what about the technique, rather than getting scared that, see, there is such a big prostate, we can't understand what is happening, and then you get scared and you may not replicate. But don't think like that. We are all, same. There is a learning curve. If you do more and more cases, you will learn. For example, if I talk about myself, I actually never had to convert from HoLEP to TURP. So persistence and perseverance, it helps. Of course, having a mentor is important. So I'll just talk about some tips and tricks of laser enucleation of prostate. I've kept it common as laser enucleation rather than classifying as HoLEP or THUFLEP or THULEP, because now there are all sorts of machines in the market and different people have different machines. So yes, there is a learning curve, as has been discussed. It is a steep learning curve. Mentorship is very important. There are two ways of making this curve achievable. One is mentorship. Second is by doing regular cases. So one has to do at least 20 cases in a short duration to understand the technique. Don't keep waiting for that large prostate. Do regularly. Don't wait that I will do once in 6 months, because if you want to understand the technique, you have to do regularly. There are certain difficulties that one faces. One is loss of plane. Second is bleeding and hemostasis. Hemostasis is a little difficult with laser compared to cautery. Bleeding is lesser compared to TURP. So that means this difficulty you will face less often if you are in the right plane. The technique of proper morcellation is important to understand. Vision during morcellation is important. That's why you should do a good hemostasis in the beginning of your HoLEP practice. Don't shy away from using a ball cautery and coagulating before going ahead for morcellation. Of course, there is a risk of bladder injury. These are the instruments I use in my setup. I use a regular Karl Storz inner and outer sheath. Same we use for TURP. And we use this Karl Storz laser working element. And also we have an Indian working element, which is actually from some manufacturer is from Kolkata itself. And this is the morcelloscope from Karl Storz. There's a bridge is used to attach this to this outer sheath. This is the 30-degree telescope. And this is the morcellator blade assembly, same what we used today. So HoLEP is a combination of enucleation and morcellation. Enucleation can be done by 3-lobe technique, 2-lobe technique, and en-bloc technique. In 3-lobe technique, we give laser incisions at 5 o'clock position, 7 o'clock positions, and then we do antegrade enucleation of median lobe followed by lateral lobes, like we did in the case today. It is used mainly for larger prostates with a large median lobe, just like the case today. 2-lobe technique, we give 2 incisions. One is at 6 o'clock position, the other one is at 12 o'clock position. It is preferred for prostates which don't have a large median lobe. So it's easier to do that way. If you like to do 2-lobe technique, you can also do for a median lobe patient, but then the floor incision will have to be either 5 o'clock or 7 o'clock and at 12 o'clock anteriorly, and then you enucleate both. In en-bloc technique, we don't make any incisions from bladder neck to the veru. We make directly the apical release incision, and then we go about enucleating the adenoma as a donut. There is one more technique wherein you can use one incision and still enucleate the whole adenoma as such. Change nahi ho raha? Oh, okay, sorry. Yeah, how do you choose? We discussed this partly. So for 3-lobe technique is preferred for a large gland with a large median lobe. 2-lobe technique is preferred with a small gland with no median lobe. En-bloc technique is preferred in smaller adenomas, and it is to be attempted only after a certain level of expertise. It is important to understand the demarcation between capsule and adenoma. Can you switch off this light? Ye light off ho jayega. This question was asked to me during the demonstration also, how to identify where is the capsule, where is the adenoma. This is the capsule, the shiny white transverse fibers that you see are the capsule. The fluffy whatever you see is the adenoma. Again, shiny white capsule, fluffy adenoma. Sometimes you might get nodules like this, so you just get under the nodule, you will see shiny capsule, adenoma, shiny capsule, adenoma. Here it is a little deep, you can make it out. So this is a clip showing what exactly we have to divide. When we see the capsule, some of the fibers of the capsule stretch up and those are they become vertical, and those are the ones we are supposed to divide. Again, see, three-lobe technique is the basic technique which all of us should know before proceeding to other techniques. This is the 5 o'clock incision of the three-lobe technique. We start at the natural groove from the bladder neck and come till the verumontanum. Then we make a 7 o'clock incision. Then we connect these two incisions, or we can connect beforehand like we did in the case in the morning. And then we go about enucleating the median lobe. Then we make the 12 o'clock incision. Then the apical release. Oh, this should have played. Okay, it's not playing. Can you? It's okay, it will come again during the video. It's okay. Then we go about enucleating the left lateral lobe and then the right lateral lobe. And then we do morcellation. For morcellation, as has been stated multiple times today, excellent hemostasis is a must so that you see it clearly. This is an old video, 2016. The bladder should be kept full. There should be no hurry in morcellation. Better to be slow and steady, especially in the initial part of practice. See, there's no bleeding. It's nice and clear. Those are the small nodules. We pass the morcellator. We press, half press and catch the adenoma. It's an unedited video, so. And then we should lift it a little more as well and come to center of bladder and then morcellate. Morcellate, stop, morcellate, stop, morcellate, stop. Wait for the bladder to get full. Okay. So this is a video of the three-lobe technique. First step is the cystoscopy, most important step. Note the anatomy of the prostate. Note whether there's a median lobe or not. Note where the orifices are. Keep it in your mind just like a GPS, where the orifices are so that you don't injure them during the procedure. Then we make a incision on left side, 5 o'clock position. That's the veru. We deepen this incision. We can make out the capsule and adenoma there. Then we make incision on right side, 7 o'clock position. You can see the hand movements as well. We deepen it till the capsule. We connect these two incisions. We see some fibers standing up there. As we go about dividing these fibers, the median lobe keeps getting enucleated towards the bladder neck. Then near the bladder neck, we don't try not to go inside the bladder, fire right on the capsule so that these fibers are released and the median lobe goes into the bladder. Some mucosal attachments you can just push away. You come back to veru, rotate the scope 180 degrees, make a marking of the distal limit anteriorly because there is no natural marker there. Make the 12 o'clock incision. That's a mistake there, it's not 6 o'clock, it's 12 o'clock. Do a to and fro, make a trough. Then this is what is the apical release is. You start from 6 o'clock, you go till 3 o'clock along the contour of prostate. Then you come from 12 o'clock to 3 o'clock position. Connecting that. Now the left lobe is released. Now same thing on the right side. 6 o'clock to 9 o'clock position, and then from 12 o'clock to 9 o'clock position. This is why we need a rotating type of resectoscope or inner sheath. Then we start with the left lobe enucleation. We start from floor and come laterally, and then we come from roof and we come laterally. So we connect these two incisions, and then we go about enucleating the lateral lobe. So this is coming from roof below. Then we connect these and we go about enucleating the lateral lobe. After this, the procedure is just like how we did the median lobe enucleation. Gradually we move towards the bladder neck and we enucleate. Hemostasis can be challenging, as I said. There are two ways of doing it, either using the different setting or different pedal, or by defocusing, how I do it most commonly. I just come a little behind. I focus on the bleeder with the laser beam, and then I fire, achieving good hemostasis most of the times. To avoid undermining of bladder neck, we discussed this during the case also. We go inside the bladder neck and we try to come under the adenoma. If we try to do complete retrograde enucleation, we can cause undermining of bladder neck. So this is one trick which helps. Sometimes there will be a large median lobe where ureteric orifice is not visible. So in such cases, either you little bit dip it and see it like we did in the morning case. But best thing is that if you're not seeing, just make incisions. After you've made 1 or 2 cuts, you will be able to see the orifice, because as you deepen the bladder neck incision, the orifice tends to draw away from the bladder neck. So it makes it safer also, and you are sure also that you are not injuring the orifice. So this is the second cut I'm making, because in this case we could not see the left ureteric orifice. Once more. The incision should always be complete till the vero. If we stop in middle, then we create, it becomes difficult to make the same plane all through. So now you can see the orifice. I just saw it, and yeah. So see, now you can see the orifice, what was not seen earlier. So now one can cut more boldly. Sometimes there may be bleeders which are not amenable to hemostasis. You try to coagulate, you try to change settings also, still not happening. Don't worry, just go to a different area. Most of this is just venous bleeding. When you're operating in different area, the adenoma would cause pressure over that, and most of it would stop. Even if it is not stopped, when you go about enucleating the adenoma and you're back on the capsule, you will be able to see it and you will be able to coagulate. And towards the end, if required as a beginner, don't shy away from using ball cautery. There can be capsular perforations. Most of them are superficial perforations only. Not to be worried about much. Like you see here, I have caused a capsular perforation here. What has to be done is, don't go about enucleating in the same plane. You are not doing a radical laser prostatectomy. Just change your plane during the next cuts. Try and be more superficial in the later cut so that you don't go on increasing this perforation. But identification is important. So now you can see fat there. So we go back to the bladder neck. We try to change the plane. See, like that. And then we correct, and then we follow the correct plane. So my take-home messages would be, HoLEP is a simple, straightforward procedure. Don't be scared of HoLEP. Patience, persistence, perseverance is the key. Start with laser BNI in five cases, as we mentioned during the case. Then you do median lobe enucleation for 5 cases. Then you go about doing the complete enucleation. When the plane is correct, the bleeding is less. You do early apical release, there will be less incontinence. And whenever in doubt, go from defined to undefined area of enucleation. We saw this in the morning case. Thank you.
Thank you, Tanuj, for a very enlightening talk. So the take-home message is persistence, perseverance, and do not be afraid of HoLEP. But we need a mentor. We agree on that. So go from a defined area to an undefined area. Don't go into the same plane if you have to recognize those superficial perforations. So I think, thank you.
sort of a left medial lobe sort of thing. It is more towards the left side. And
What will be your plan in this case?
I will go with two lobe technique.
Two lobe. Okay.
Sister, give me the dilator. Pura set. Okay. Oh, that is Olympus one, no? Hey, wolf. Give me jelly in the syringe. Okay.
You are going to use the metal dilator, sir?
I use metal dilator only for the meters part, but I feel like that this is the narrowest part.
Yes.
And if you are able to dilate it to 28 or 30 French,
Yes.
it will serve our purpose.
Correct. And that is the most common site of stricture formation
Yeah,
also
yeah.
later, submeatus.
Sister, no, sister, this is, you are not giving, this is the last one. Sister, put in jelly here, unless until the tip is cut. Only tip. Yeah, next one. Next one.
I believe you should do a Otis, Srinivas, no?
No, it's not fitting into it. You can give me a jelly in syringe. It's not the way of giving. It's a 10 ml syringe in na. Give me the dilator. Actually, you have got two sets of dilator probably. दोनों अलग-अलग dilator हैं. Yeah, that is the reason why I am finding it difficulty. If that is not the case, let us give it a try. Sister, just hold करो पहले से. Otis is not.
Someone is standing in way of the camera.
Nah. Give me the. Water inlet, which one is the correct one? Sister, you don't have visual operator? Visual operator है? नहीं. This is the instrument, sister. ठीक है. Don't. That's what I'm telling you. Na. I feel like that the ends are quite blunt. Are you getting the end of view?
Yes, sir. Yes.
So we are in. Just decrease the height of down as far as possible. Yeah. Oh, sorry. Can you have chair?
ज़्यादा नीचे हो गया क्या?
थोड़ा सा ऊपर कर दीजिए बस.
ऊपर कर रहे?
ना ना ठीक है.
Which laser resectoscope you use at your setup, sir?
This is a Karl Stoves one. Sister, outlet लगाना.
I think most of us are more comfortable with the stores.
This is the most common one used.
Yes.
So it should be 2 and 30.
You use 30 hertz frequency, sir?
To 30 hertz and 2 to start. So now we are start. Are you getting end of view?
Yes, sir.
Yeah.
Why do you prefer 30 hertz, sir? Because
It's more of a hemostatic one. That's it.
okay.
Yeah, ready. The first incision is an.
End of view, please.
I'm not getting end of view.
Yes.
The water is not going.
We are
You have to
getting
open
those
both the
lines.
waters. Both the waters simultaneously. Yeah.
Even with this machine, we are getting those lines.
It is all same. We change the machine just to see whether we can get rid of those light, but it's still stalled there.
It is there.
So the initial incision, a horseshoe one, and thereafter once we are able to see this vertical fibers, we will change our scope to upside down. And
Why do you turn it upside down, sir?
the appreciation of plane becomes quite easy. You can see just I am trying to get into the plane and it goes nicely without any trouble. You can enucleate it, go as far as possible. You can see the fiber, capsular fiber.
Yes.
We work on the plane, the fiber is more towards the adenoma rather than towards the capsule, so that capsule should not get injured. And we work our way as far as possible towards bladder neck. So here you can see the entire prostate is lifted up from all the sides posteriorly.
Yes. Don't you get tempted to do unlock the way you're doing it? This is what I would do in unblock. Almost, I think you're very close to bladder neck.
Yeah. Now I will stop. Now I will stop. I will come back. The entire thing is lifted posteriorly with Veru as a marking. I will put in an incision, taking the median lobe to one side. Since it is on left side, I will put an incision here. At this very time, I will close the outlet so that the bladder is full and the ureteric orifice goes back it shouldn't come in my way. Once you deepen this thing, you will see the lobe separating on its own. And that is the end point when we can say that we have reached capsule. You go on doing it.
Right. Beautiful techniques.
The entire lobe goes to one side.
Yes.
You can see the capsule. Let me separate it out. Now I will join these lobes. So now since we have reached the capsule, both the lobes are already away from each other. They have separated on their own.
Yes.
I will do something.
The medial lobe would come out with the left lobe.
Left lobe. Again I will go in beneath the adenoma on both the side, enucleate it as far as I can. It will decrease.
Right.
So it goes nicely without any trouble. So here it has been lifted up. Same thing we will do here also. More of a medial dissection rather than going anything lateral, so that we reach up to the capsule. So the entire thing has been enucleated posteriorly.
Yes.
Now comes the upper one. Again the same, since we are not having any landmark there, try to control the bleeding if it is possible. Taking Veru as a landmark, we will go upstairs. Here, this is the mark, we will go inside. So very less of a tissue on anteriorly, and we will work our way from the area where we have put an incision towards the bladder neck. We will not come back. And laterally, we will try to separate both lobes anteriorly from say 12 o'clock to 10 o'clock and 1 to 2 o'clock position on both the sides. And the weight of the prosthetic lobe itself will drag it down. So one by one, here I am trying to bring it down laterally. Again, now I will work my way here only. It decrease as far as possible, working near the bladder neck. I will not come back. And you can see the capsular fiber everywhere without any trouble. Having done this part, I will come back and I will put an incision.
Right.
The incision will be only in the mucosa. After giving this incision, I will go from inside and I will scoop it out without giving any incision into the tissue, so that it comes on its own.
Again, you have reversed the.
Yeah. Most of the resection are in this reverse position only.
I think there's so much we can learn from each other.
Yeah. Again, we are seeing the attachment here. It's inside our thing. Again, I will cut at this position, and again I will go beneath the adenoma, so as to scoop it out, and you can see it comes on. Then I will come from above. This is the point where we have done. Thereafter, we have to see what is the part that remains. This is the only. Huh?
Where is the sphincter?
Sphincter is here. You can see this is the sphincter. It's very, very quite behind. So this is the area you can see the attachment. Put an incision. Since we have brought it down from above also, it become easier. Once you are done with this part, rest of the things is a cakewalk. So we are not leaving any tissue at all, and we are still staying beyond Veru. We are not crossing the Veru. It's at the level of Veru itself. The chance of sphincter injury is less. This is our original incision. Once this is down from here, now again it's just a lateral attachment which we have to take it out, and we are through.
Very nice.
Once we are near this bladder neck, I will close the outlet so that the bladder fills up nicely and the ureteric orifice goes back. It is still attached somewhere. Yeah, this is the part it is attached.
Mostly in that area only it will be.
Yeah, this is attached there. It has gone inside. We will do some sort of coagulation. With 30 setting, it's advantage. You don't have to change the settings also.
Yes,
You can do the things. So since I am working with a single pedal,
yes.
I have deliberately kept at 230 so that I can deal. So we are done with this lobe. We'll now move to the next lobe. The same thing. We'll try to bring the lateral lobe near the bladder neck as far as possible. It goes nicely. You can see circular fiber all around. Actually, we are not used to working with this.
I know the difficulty. But still you are doing it very nicely.
So
Ultimately it is the man behind the machine. Actually the camera is a bit tight.
Camera, the movements are not that smooth as is done. Now we are left with this. We will again mark the incision here itself at the level of Veru. And it will be only a mucosal incision. I won't be using this incision to get into the prostate. Because the prostate is beyond this very incision. And I will try to bring it down here. And again, the same way I will go from, this is the Veru, I am going in front of Veru, and I will try to scoop it out. Again the same thing, movements are quite restrictive.
So again, see, the distance what he is keeping is similar to what I was saying. Where you
Yeah.
see that silvery halo means you're at right distance. If you're too close, there will be charring. If you're too far away, it won't accept it.
By Joe. So now, since we have scooped, we can see the attachments here. Just go on at detaching those attachments. Half of the things will move on its own, even without cutting.
Can it be focused a little bit?
Yeah, I'm trying to. This is the probably. So entire thing is getting scooped up from inside only, without crossing the Veru. Only difficulty I am facing is that the camera is not that mobile, and since we have to have a good mobile camera. So now the only lateral part is remaining. What I feel like that going beneath this thing, adenoma, gives you a better appreciation of the planes.
Yes.
And it becomes quite easy to pull it out, except for the last part where we have to do it in a normal way, because otherwise the chances of subtragonal is quite high. So it goes like, and we have to follow contour of the prostate as we go up. As we are near to this bladder neck, now I will again change this to the normal position, and there's a test somewhere. Increase to 40. 40.
Why are you increasing the frequency?
Yeah, because I think the tissues are quite tough. It's not cutting the way it should cut.
It's more sticky.
And that's it's quite sticky here. So I feel like that.
But energy would be same?
2 joules.
So I have seen some people at this particular point, they want like to do the maneuver that you do in rest of prostate, where you keep the...
I have closed the outlet right now so that it goes nicely.
Very nice. I think every day you would be telling your wife कि रोटी बनाना शुरू करो, मैं एक HoLEP करके आ रहा हूँ.
So we are done with this thing. We will see how the morcelate behaves with me. Okay, 30. 30. Make it 25, 25, 25. Yeah. So we'll do some sort of hemostasis. I have decreased the settings to 2 and 25 for coagulation.
Right.
And probably here and there we will find some bleeder.
Now those lines are not coming, I think. The disturbance what we are getting earlier. Lower part. You keep the pallet rate off always?
Yeah.
Any specific reason?
Because they don't help me. So we are very far away from the ureteric orifice, both the ureteric orifice. Now I think we are having a good vision. We can proceed to this morcellation.
Definitely.
चलो, sister, stand by कर दो.
Stand by.
And ये morcelloscope. Morcelloscope. इसको निकालना होगा पूरा. ये ना आउट इनर. नहीं नहीं.
Same like torso. You take out the inner sheath, but you will have to change the inflow.
Oh. सिस्टर इसको सेट लगा.
Sheet भी out होगा.
हाँ. आउट हो गया.
How is your incidence of stress incontinence?
It is same. I mean, initially we used to have stress incontinence quite frequently, and it was quite distressing also. Just to put in a light. Now the stress incontinence, a temporary stress incontinence, somewhere around 7 to 8%, and long-term incontinence that is persisting even after 6 months is 1 to 2%.
Any specific tricks you use to prevent that?
That is the early release, and second, I tend to scoop it out from inside rather than going from Veru at the level of Veru inside. I always remain inside Veru and scoop it from inside with the help of laser, even if it is hanging beyond Veru. सिस्टर एक ही इनलेट है, दोनों चालू नहीं. It should work. एक और दे दो इधर मेरे को. इस आई एम नॉट कंफर्टेबल विद दिस. एक और लगा दो तो. जनरली ये थोड़ा सा नज़दीक लाना पड़ेगा. इट्स टू फार ब्रदर. ये नहीं आएगा, नज़दीक नहीं आएगा. हाँ या ब्रदर उसमें पानी नहीं जा रहा है. उसको प्रिक किया है. विदाउट प्रिकिंग पानी नहीं जाता है.
It's a little better now.
अब जाएगा, सब हवा भी जाएगा. गिव इट टू मी सिस्टर. कैन यू चेंज दिस. क्या कहते हैं? ओह, इट इज़ हियर.
tips for oscillation?
It's the same what you have been telling, because this modulator will test you like anything.
It is. It has supported us for years also.
Yeah, that's there. Now since we have used the other modulator also, now we always think of ki.
There is a joke about the wives and mobile, I think.
So the tip is, you should work near the bladder neck, never go deep into the bladder. Just suck it, bring it near bladder neck, and it should point towards anterior wall. But again the same thing, what was happening with you only.
I think you're angry with your current girlfriend right now.
Yeah. What is the suction one?
मीडियम में क्या हुआ?
सक्शन फुल कर दो, सक्शन फुल करो, सक्शन फुल करो, सक्शन फुल, और उसको थोड़ा और बढ़ा दो, मीडियम में करो. यस, लेट अस सी इफ इट वर्क्स. हाँ, सेम सेम सेम. This creates some trouble. ये कहीं ब्लॉक हो रखा है क्या? हैं? नहीं नहीं, ये ब्लॉक हुआ है कि नहीं? Tube is blocked and suction is coming. लगाया? Yeah. उसका if suction is not working ना, then it will not catch. Moment you go near it, it will turn में ना. It has to. Again it is leaving, and this morpholoscope is not compatible with this everything. The movements are jerky. It should not be. Movements here, it is a jerky movement. The Morse-Low scope is not compatible with this one, and now it creates some trouble. Dear, change the water, change the water. हाँ, उसको खोलो, है नहीं हो,
चेंज कर दो,
उससे काम नहीं होगा. Yes.
Only small nodules are left now?
Yeah, same. It is a story with every prostate.
So in en bloc we always felt that it will be a faster oscillation also. But in en bloc also in the end there will be some nodules. Like this.
नीडल दे दे.
it becomes a cat and mouse game with this morcellator.
Sorry?
It becomes a cat and mouse game with this morcellator. I mean, it will catch at some time, and I feel like this morcelloscope is not compatible with the Bursa cut because it's not. I'm not having this a jerky movement.
Right. That's because of the rubber.
Rubber.
Rubber shot. It is a bit tight. But it also prevents leakage of
Yeah.
water.
And the trick is never chase this type of thing. If it
Yeah,
comes
yeah.
on its own, well and good, because chasing will
Yes.
lead you to the wall and it
injury.
will create more trouble.
Correct.
So,
They should come out.
sister, can you keep it this? Let me see. Was नहीं नहीं. Sister, ये तो मेरा भाई जो. Probably it has come out.
Yes.
Let me see. Let me see. So, again checking the ureteric orifices in the bladder.
Perfect. Very nicely demonstrated.
So it's even at later stage you feel like that there are some bleeders have cropped up during your morcellation. You can again go inside with the laser and do the coagulation if needed. But I don't feel like it requires anything.
I feel this it's all generally very mild venous.
See, you can see the spincher here. Is a Veru here, 20 French 3-way. Okay, this is a mild bleeder here. It will stop on its own.
Yes, yes, yes.
So I think I am done with the operation.
Perfect, sir.
You can see the flow.
We can't see the flow, but I think it definitely should be very good, sir.
Can you see?
No,
No,
we can't see.
no.
The camera person has to show.
No.
Oh yes, perfect. I keep an indirect measure. If the flow is reaching the assistant who's trying to run away from the flow, that is a good flow.
Yeah.
So the moment I take out the endoscope, all my assistants run away.
That's true. That's true. Slowly, slowly.
Very nicely demonstrated, sir.
Thank you. Thank you.
We are waiting for you to have start lunch.
Just coming down. Sister catheter? दे दो जो आप लोग जो यूज़ करते हो दे दो 22 दे दो if you 22 दे दो 3-way ही होगा. इरिगेशन लगा दो सिस्टर. इरिगेशन सिस्टर 30 ml. इरिगेशन है नॉर्मल. IV सेट. Thank you, boss. इसको निकाल.
small is always beautiful. Gathering is small, so you can interact better, you can learn better from each other. So I welcome Dr. Srinivas for this talk, because it's very important to avoid complications. And the most important advice in avoiding complication is to recognize it early. So if you can recognize it early and how to tackle it, Dr. Srinivas.
Good afternoon. Welcome to this post-lunch session. Most of the topic has been already covered by Dr. Tanus. We'll still see. So, first and foremost question everybody is asking, when we are so good at doing QRP, what is the need for doing an HoLEP? As you can see, this is the only organ that has been sacrificed, charred, burnt, ablated, resected, but not. HoLEP, we all know, is an endoscopic replication of open Freyer's operation, where the adenoma is enucleated, morcellated and removed. So what are the advantages? Why we want to learn this procedure, why we want to do this procedure? First is, you see, anatomically, it is an enucleative procedure, just a replication of open procedure. So entire prostate is taken out without remnant. And method is same irrespective of the size, be it 20 gram prostate or 200 gram prostate, it is the same process. It is amalgamation of best of TURP, as it is an endoscopic procedure. Open prostate, it is a complete removal of the prostate, and second, there is no TUR syndrome as with Barler. Plus, it is safe with antiplatelet. You can go on doing an HoLEP with patient with platelet on. We tend to stop clopidogrel if required. It is affordable, unlike green light, where the single fiber is not a reusable fiber. And unlike thulium and green light laser, there is no scar formation. So this all have been discussed. It can be done for any prostate size, any age, and most of the associated comorbidity, provided that the patient can be taken into hospital. So it's a new gold standard. It has stood test of time for last 25 years since the Peter Gilling started doing this procedure. And it has plugged all the gaps in the TUR armor. And there are numerous studies that are available that certifies that it's still gold standard. So what are the criticism? Why we are so lagging behind in learning this procedure, which has been there for last 25 years? First, as we have discussed, as Dr. Mishra has also told about the long learning curve. Second is a time-taking operation. And third, there is a curse of stress incontinence, which we all discuss. So this steep learning curve, although no doubt there is a steep learning curve, but we have learned laparoscopy also, which has got a steeper learning curve as compared, because we don't have any other option. Most of the time, this steep learning curve, we tend to convert an HoLEP operation into TUR operation. If you are keeping your TUR set in the trolley by the side when you are planning to do an HoLEP, probably you will end up using the easier method, doing an TURP. So most of the time we are not able to acquire the full skills. Why it takes long time? We are attempting on HoLEP surgery during your initial part on a larger prostate, which you won't be able to handle. Not allocating, you are keeping one case before and after the HoLEP, and you are on a horse to complete it as quickly as possible. You have not acquired the skill. You are mixing TURP with HoLEP most of the time. And if you go on operating, you take long hours, there is a complication, anesthetists are also not happy. And fact of the matter is, it's not a long process. Endoscopic enucleation HoLEP is the fastest method of doing a prostatic operation. High incontinence rate, although during your initial days, you will encounter the immediate post-operative stress incontinence, which is somewhere around 5 to 15% sort of thing. But as you learn, as you acquire skill, that goes down. The long-term incontinence is comparable to the prostate is 1 to 2%. So coming to the complications, these are the intraoperative complications which we deal regularly. First and foremost is the bleeding, capsular perforation, fluid absorption, bladder injury, and ureteral orifice injury. These are the post-operating. First is the incontinence, acute retention clot infection, bladder neck contracture, urethral stricture, retrograde ejaculation, and erectile dysfunction. Of this bladder neck and urethral stricture, the urethral stricture, in my practice, I have seen it is the same what I had during my TRP days. But the bladder neck stricture surprisingly is quite low, and it is less than 1% sort of thing. But urethral stricture is same, around 2 to 5%, depending on the instrumentation time. Retrograde ejaculation, erectile dysfunction is all same. So we will be dealing with this complication. First and foremost is the bleeding. Intraoperative bleeding, as I told you, it is related to your skill level. Depends on prostatic inflammation, meaning by if the patient has had prostatic inflammation, prostatitis, or the patient is catheterized. Particularly in those patients, you will see the bleeding is much higher because there the mucosa is quite inflamed. As soon as you incise the mucosa, the bleeding will crop up. And I don't feel like that dutasteride prevents it, but it decreases to some amount. But giving dutasteride to a patient who is having a big prostate will land you in difficulty while you are morcellating, at least with this morcellator, because the things becomes very harder and it fails to cut. Intraoperative bleeding, you have to identify capsular plane early during the nucleation. Stay close to the capsule throughout the procedure. Third and important is the enucleate and separate the adenoma from the capsule. I will try to make you understand. Here, once I will show you the video, we have to remove adenoma from the capsule rather than capsule from the adenoma. We should be working on the adenoma, not on the capsule. Change the setting as per your requirement. And if you want to really increase your hemostasis, work with the defocus laser fiber. The laser fiber should not be touching the prostate or adenoma sorting. It should be way behind so that you work in a coagulation mode. Can you start the video? Here you can see this is quite a big prostate. Kissing lobes. This is an unedited video, it will take some time. With a median lobe, mainly on the left side. Right ureteric orifice, left ureteric orifice seen with difficulty. Then, as I told you, this is the first incision. This is a horseshoe-shaped incision just proximal to the veru. Once you have incised the mucosa, you will see the vertical fiber that are standing out. And this is the point where the capsule is easily identified, plus the capsule is thickest. So we go beneath the adenoma, and here you can see the adenoma lifts on its own. 50% is cutting, 50% is simple enucleation with the gentle force of the beak of the resectoscope. It goes without any trouble, and you should go as far as possible. So this beak, the laser fiber should be pointing and it should be closely applied to the adenoma rather than to the capsule, so that it should not enter the capsule. You can see, but it's 50% I am cutting and 50% goes on its own because there is a well-defined plane between the adenoma and capsule. So entire prostate from the posterior lobe has been lifted up. You can see the entire lobe. Next. Yeah. Plate. This is the other one. Try to learn a single technique and master it. Again, the incision is same, just proximal to veru. And as soon as you start seeing this vertical fiber, just change the orientation of this fiber. Try to get beneath it. You can see the prostatic calculi that signifies that we are in plane. And then you turn it upside down and go beneath the adenoma. And it will give you nice capsule all around without doing much cutting. I think when we are learning this HoLEP procedure, this is a nice way to identify capsule, at least posteriorly. And once you have identified capsule at one position, you can always revisit if in case you are lost laterally. So go as far as possible. It lifts us without any trouble. I mean, most of the time you will see that the flimsy adhesions are there, which goes with the big pressure only. Here, entire thing is lifted without any trouble. And since you are in plane, and since you are working with a defocused plane, the bleeding is quite less. Second thing is capsular perforation, which is uncommon. It is related to skill level, 0.6 to 10% depending on your skill. Most of the time it will not alter your treatment course, but if it is in deep capsular perforation, all you require is a prolonged catheterization. Please play it. And this usually happens with a smaller prostate rather than with a larger prostate. Technique remains the same. You have to start just near the veil. Then look for the vertical fibers so as to decide whether you have reached up to the capsule. And then you turn your receptoscope upside down. Depend on the pressure which you are giving. With small prostate, if you give too much of big pressure, it will rupture at some point. See, this area has gone down. What I have to do, I have to go one step above. Whenever I see there is this thing, I will go one step above. You can always recalibrate where you require. This is capsular perforation. I will go one step above. There is no need to abandon the procedure. There is no need to go to other side. You can work at the same plane, same place. Just go above it. Just change the things, and sooner you will see that we are in correct plane. So what we have done, we have changed the position. You go one step above. That's it. Next. So here is the plane. Again, the most discussed topic, the stress incontinence post-HoLEP. As I told you, is the most cost complication. Long term is only 1 to 2%, but short term, that is lasting around 1 to 3 months, is 5 to 12%. The causes are de novo. The patient was initially having, since he was having bladder neck also, that time it was not diagnosed. And second is the operation itself. There has been study in 2015, it came out, there are 2 independent demographic risk factors that will increase the chances of post-HoLEP stress in urinary incontinence. One is the age more than 70 years and body mass index more than 30. And we add to it diabetic patients. These are the 3 patients in whom the chances of temporary stress incontinence is quite high. So what happens during the HoLEP that leads to this stress incontinence? Why it happens? There are multiple factors. HoLEP, post-HoLEP, it requires an occlusion at the level of membranous urethra so as to provide continence. When there is tearing of sphincter muscle due to excessive use of mechanical thrust. So blunt dissection is strict no in HoLEP operation. when you are working near the sphincter with a very high energy setting. So you should decrease your energy setting to somewhere around 2 or 30, 60 or 50 watt when you are working near the Veru. And there should not be tearing of mucosa. You should put in simple plain incision at the level of Veru maintenance. And if there is a tearing, it leads to incomplete occlusion seal effect and leading to incontinence. So tips, again, first incision has to be near the Veru so that you identify the capsule. Stay on the capsule. Dissect along the adenoma. You should be dissecting adenoma away from the prostate, away from the capsule rather than vice versa. Disconnect the lateral mucosa attachment early so that you can disconnect the sphincter membranous urethra from the prostate early in the dissection. And there should be strict no dissection near the verumentanum. Can you play please? It is somewhat long. Here after doing this posterior part, we have gone anteriorly and we have marked our incision anteriorly at 12 o'clock position, and thereafter we will bring the lateral lobe down from 12 o'clock position to 10 and 2 o'clock position on left and right. The same way I have been doing for years now. This when you are putting the lateral incision, the weight of the adenoma brings it down. The same way here also. You can see the fiber nicely all around. And it goes down. Once you are done with this very part, we'll come back and put an incision. So now the incision at the level of verumentanum, and we have to follow the contour of the prostate and join the incision which we gave in anterior part. And this is the incision. This is known as the early release of the mucosa, and it should be a mucosal incision only. Thereafter, we have to work our way from above down and from below up, joining the incision in the middle. The most important is the traction which you are providing with the resectoscope sheath, because it guides you where the sphincter is located. Whatever bleeders that comes can be tackled with defocusing only. And now I will start scooping from inside. Given the incision, it will go inside and it goes on without any trouble. In this way, you have seen it's coming out as if you are scooping it out. Then you again come back, check where it is attached, put in incision and join these things. So in this way, you have released the mucosa earlier and you are working while still you are inside Veru only. You are not crossing the Veru level. Here it is important to bring the prostatic adenoma from upside down, because otherwise you will be lost during dissection, because you won't be able to join these two planes. Since it has been brought earlier, it becomes quite easy. Bottom point is you have to master a technique which suits you, and you have to keep doing with the same technique so that you master it without any trouble. And you should be able to replicate regardless of the size of the prostate. Everywhere the traction is playing a role. you are seeing a taut fibers. It is because of the traction of the beak, which gives us a insight where the capsule is located and what should be our angle or level of laser firing. And while you are working near the bladder neck, make the bladder distended by just stop the outflow. Once you are done with, here also I am putting in one incision. Just to show you the incision, it is at the level of Veru. We mark the incision, and thereafter we again go inside and scoop it from inside. Next. Same one. Yeah, this is a technique that is used during the en-bloc method of HoLEP enucleation. There the incision starts with putting in incision earliest. This is the level of the sphincter, and here the incision is given early, even before we do the posterior part. So although they claim that the chances of stress incontinence is quite less in this one en-bloc HoLEP, because of the fact first they mark the landmark early during the operation, both anteriorly as well as posteriorly, and plus they release the mucosa early in the dissection, even before dissecting. Once they have put an incision, thereafter we start dissecting on both the sides. So here the mucosa has been released at the earliest. And again the same procedure, we join these two mucosa and then start working underneath it. So these are two ways of doing it. This is for the en-bloc one. And you can see once that is operation is done, nicely coapting the sphincter at the end of operation.
हाँ मैं देखा, thank you.
So ureteric orifice injury, it is during the early learning curve.
फिर से वैसे ही करना है
0.1 to 1%. They are ready.
मॉर्सिलेशन के लिए वो वाला वो करना है. कोई बात नहीं. उनको वो लोग कंटिन्यू करेंगे नीचे, अभी तो टाइम है.
Hello.
Hello.
Are you ready?
No, we'll take 5 more minutes.
Oh, okay. So it's common when there is big median lobe, you are not able to identify ureteric orifice early during the operation. And even if you are not able to identify, you can identify by putting incision, as was shown by Dr. Tanuj. If it is close, very close to your bladder neck, and you are not able to see, always distend your bladder while we are working near the bladder neck, so that the ureteric orifice moves down. If there is a partial injury, you can just absorb, but if in a deep, this type of injury, you put in stent and come out. Bladder injury, as I told, it is uncommon, mostly seen during the morcellation in early days. And superficial will not alter your treatment, but deep significantly will ask for an exploration sort of thing. You can manage with catheter if it is a retroperitoneal, but open repair is required if it is interperitoneal or there is adenoma is still there. Some morcellating fossa to prevent it, but morcellating fossa requires another level of competence because there the mucosa will not move around. There is less of a limited space there, and you tend to catch hold of prosthetic capsule instead of the adenoma. So this was what I was trying to. Can you play the first one?
Beta D.
First one is the to and fro Versa cut which we are using.
Beta D.
You see the things. The
Beta D.
cutting part is the outside part. The again you play it again. The inner aperture is for suction, so it tends to pull the bladder mucosa inside and leads to injury.
Jelly.
Yeah, same. Second is the piranha one. Yeah, entire thing is moving inside.
ये बहुत बड़ा है.
And it will never catch hold of bladder mucosa unless until it is deliberately kept near the bladder mucosa. And that is the difference.
तब थोड़ा छोटा हो सकता है, हाँ होगा तो better है.
It is, the entire cutting area is concealed. Entire cutting area is concealed, it is not exposed. Where in case of this Versa cut, to and fro, it is exposed. Next one. So, morcellation injury, as Tarun was telling, the perfect hemostasis is the first and foremost requirement. Don't be shy of using a ball cautery if you are not able to achieve it, because you cannot do morcellation without having a clear vision. Second, as I told you, fill the bladder to capacity. Work near bladder neck. Once you catch up the prosthetic tissue, bring it near the bladder neck, pointing towards the roof, and then start morcellating it. Don't chase small tissues that has gone inside, moving around in bladder with morcellator, because you will end up sucking bladder mucosa into the morcellator. And in case if it is a big prosthetic adenoma, you are not able to morcellate it nicely, there is a vision problem, please stage it. You will be able to do a very easier job 2 days after the procedure. You have to catch hold of this thing. Earlier, everywhere the Versa cut is there. Now, more and more hospitals are buying this Piranha system because that is safer one, and it's faster also. Okay. So, this we all have discussed. How to learn thing, you have to give at least 1.5 hour time, space with other TOP, pick smaller prostate. If you're a larger prostate you still want to do, you can do one lobe only and do morcellation some other day. These are the 3 types, and a 2-lobe, 3-lobe and N-block. There are 2 ways of doing it right now, that is 2-lobe and N-block. 3-lobe technique is good to attain some sort of capsular anatomy during your initial days, but everybody will be doing either 2-lobe, and once you acquire some skill, you can try N-block technique. But 2-lobe is the standard, regardless of the prosthetic size, regardless of the median lobe level. You can always carry median lobe to one side and do a 2-lobe procedure. So these are the tips of safe procedure. First, you identify the capsule by working near the verumentanum, stay on capsule, disconnect the lateral mucosa attachment early, dissect along the adenoma, dissect the adenoma from the capsule rather than other way around, and there should be strictly no blood dissection near veru. So don't be disheartened, everybody is legendary at something. Thank you. Tarun, are you able to hear us?
Yes, yes.
Yeah.
Can you hear me?
Yeah.
So it is a big prostate, as you can see. I have already done the cystoscopy and
You are not getting endoscopic view.
Endoscopic view दीजिए. Are you getting now?
Yeah. Tanuj, are you okay?
Yeah, okay.
Okay.
This is a big prostate. This is a veru. Again, median lobe, large median lobe, and lateral lobe.
You are getting same type of prostate.
Yeah. Last 1 year I have been operating all 100 kilogram plus. So wherever I go, that's fine.
Can you put on OT lights? We are not able to see him. Yeah.
So I'm thinking of doing a en bloc in this case, just for demonstration.
So Tanuj, can you ask Ambreen or Goel to give a brief about the patient?
Can someone present the case, please? ये अंदर नहीं जा रहा, उधर ही रह रहा हूँ। नीचे लगा दीजिए स्टूल। स्टूल।
Sir, can you hear me? Sir, 63 years male. Patient presented with acute urinary retention 1 month back.
इसको थोड़ा घुमा दीजिए।
Ultrasound 103 cc prostate. PSA was 7.5. MPMRI was done. Pyrex 2. Biopsy done.
ये बहुत बड़ा
BPH.
सा बकेट है, इसको छोटा रख सकते हैं इसकी जगह।
Failed voiding trial. Now on follies since last 1 month.
नहीं, यहाँ से मोड़ना है, यहाँ से मोड़ना हो जाता है। रहने तो अब मत करो, मैं देख लूँगा।
Why was biopsy done?
Sir, PSA was 7.5. Biopsy was done outside hospital.
छोटा रख दो यहाँ पे, टब छोटा।
Not in medical.
ये छोटा टब रख दीजिए, जगह ही नहीं, मेरे लिए जगह नहीं है।
Size of prostate itself is too big, no?
Yes, sir. 103 cc.
So we are using.
You do a free PSA, total PSA ratio in this case before thinking of biopsy, isn't it?
Exactly, sir. But we didn't do the biopsy here.
Yeah, I got your point. Yes.
Sir, we are not using free PSA much. We are relying a lot on MPMRI now. What is your take on it? Can you hear me?
Yeah, I can hear you. I'm Dr. Sujit Sinha. I do a lot of free PSA, total PSA ratio. And I can tell you it has not failed me much. It has failed me one or twice, but it hasn't failed me much.
Okay.
So, yes, I do MPMRI as well. Yeah. But only when the free PSA, total PSA ratio
is abnormal.
Gives me a case. So the cutoff that I take as free PSA, total PSA ratio less than 18%, I would go for a biopsy.
Okay.
More than 22%, I won't go for a biopsy.
Okay, okay.
That is how I follow.
Okay.
18 to 22 is equivocal. I would again do a repeat free PSA, total PSA ratio after 3 months.
Yeah. एक मास्क ला दीजिए। Sorry.
Tanuj, as I remember, this patient had got a UTI also after biopsy.
Yes, sir. I haven't told that.
Yeah.
इसको we are making just a few arrangements here, few changes. Just give me 5 minutes. रख दिया? Okay. So generally we prefer a high lithotomy sort of position. This because of previous TKR they have given this position. Let's see if required we'll change it. So we can do 3-lobe, 2-lobe en bloc. What I'll demonstrate is a different type of en bloc that I do, wherein I use a midline incision anteriorly, and then we do a en bloc all around. Something I described as miracle technique: midline incision, release of apex, and circumferential laser en bloc enucleation.
Tanuj, so, there is question, I mean, how to decide whether we are going to do en bloc or, 3-lobe or 2-lobe?
Sir, ideally in bigger prostates, it's better to do a 3-lobe or 2-lobe. En bloc advantage is that it is generally faster. Like this is a very big prostate, generally it will take some reasonable time for enucleation. En bloc would save some time, and because as we become more experienced, I know that the only way for me, one of the ways for me to bring down the stricture rate is to have a shorter operative time. So en blocs help in shorter enucleation time, and also when you are
enucleating the entire adenoma as one, even the morcellation time is supposed to be lesser.
Okay.
So, रहने दो better है. So, again, we'll start in the same way as a V-shape incision here. Okay. Then we'll reverse it and mark our anterior distal limit. Then we'll give the anterior incision. So anterior incision is the only incision I am planning to give in this case, and rest of the adenoma I want to take out as en bloc. That is my current plan. Laser ready, please. I am again using the Moses fiber. You can make it 2 joules like it was earlier. Your usual setting. Standby okay hoga. Yeah, ready. Okay, so this is the Veru. We make our first incision. The lines are back.
These lines were not there when you were operating, right?
So like Srinivas sir did, we will now slightly lift the median lobe as much as we can from here itself.
Again, the screen is showing
lines,
the horizontal lines.
Yeah, I don't know how to decrease that. नहीं उसमें शुरू में आ रहा था बाद में चला. So we'll go till whatever level we can go, easily, comfortably. 3 lobe. These are the vertical fibers which we are supposed to divide. Okay, so we have lifted it from here. This is the Veru till here. Okay, little more I think we can do, and then stop. Okay, so now we come back to the Veru. Can you appreciate, sir, how much we have lifted?
Yeah,
yeah.
You can see.
Now this is the Veru. We turn our scope and we make a distal marking. There is a decent amount of tissue anteriorly also here. So it will take some time for us to reach that plane. We go on doing, vision will decrease, wait for it to clear, then deepen it further.
Tanuj, what energy setting you are using right now?
2 joules and 50 hertz, sir.
Oh, you've gone
This
to
is Moses fiber 100 watts.
100 watts.
This is a 120 machine, and we are using 100 watts in that. Now if I want to do a donut technique, what I will do is the same thing I can continue till there.
Okay, yeah.
I'll show you, till the bladder neck.
That's the original en bloc technique.
Yes.
There's a difficulty while you working, the vision goes.
The vision goes because the flow is not very good. So now we will come from inside the bladder neck till here. As I said, there is a decent amount of tissue anteriorly. See, this is the median lobe, and it is almost
touching.
We'll deepen this. See, when there's a lot of tissue anteriorly, the torque can trouble you.
Yeah.
So it's better, that is where this incision helps. If you place it initially only, the struggle at this area, it decreases to some extent.
True.
Now the trough that we create, can you appreciate the trough that is being created?
It's getting widened.
Yes. So now our incision is done. Now we'll do the apical release. Same way how we did earlier. This is the veru, this is the sphincter region, and we'll make an incision along the contour, first from below above, from 6 o'clock to 3 o'clock position. Now from 12 o'clock to 3 o'clock position. Same thing on the other side. Oops, fiber weight has gone. हाँ ठीक है निकाल दिया मैंने. Camera tight है. From 6 o'clock to 9 o'clock. Actually it's gone almost till above, but we'll still correct it from here. This is our incision from above below. Okay. Now we'll deepen these incisions. We have planes created at two places. One is here, second one is above. So we'll enucleate further along the planes and connect the two. Pilot light maximum पे है. Pilot light is maximum. Is the pilot light or maximum? Pilot light. Aiming beam. Maximum करो. हाँ नहीं blink नहीं करना. हाँ maximum. Yes, thank you. Ready करो. Ready कीजिए. Ready है. Can you appreciate the lobe getting lifted, sir?
Yeah. Nice plane there.
Now we'll come from above below.
See, with HoLEP, we really need a very free flow from the camera, from the endoscopic camera. Because this one is a little tight, it becomes little difficult to rotate the scope. The same difficulty Dr. Srinivas was facing.
Yeah,
Yeah.
that's great scope. Because with such a big size prostate, you have to move your hand
Quite a
to
bit.
wider.
Yes, sir.
It creates some trouble sort of thing.
पानी में होल है ना? पानी तो है. Really rotating this is a challenge. This is the sphincter area. Can you see?
Yeah.
That is the adenoma. Pani, please.
पायलट लाइट मीडियम कीजिए फिर से, एमिंग भी मीडियम ही कीजिए.
Tarun,
Yes sir, please.
why are you decreasing the pilot light now?
I thought, so generally I keep it on. It helps me mainly in hemostasis and to see the target area. But I think it was creating more of a
Visual disturbance.
yeah. Because already there are some lines and these things, and I was not getting very good vision. I think this Moses pilot light is more bright than our usual pilot light.
Green light, yes.
Yeah,
Are you sure it's Moses or green light laser?
No, this is Moses.
Just-
Yeah.
So in the meantime, there are questions from one PG regarding PSA and antibiotic and then repeat the piece, right? Yeah. So, in this case, like it was 100 gram prostate, PSA was 7. I don't think there is need of antibiotic and repeat the PSA.
Yeah,
So you can do the DRE, maybe you can do the MRI, and if you feel it's a 100 gram prostate, MRI is normal, DRE is normal, there is no need of repeating the PSA. Before doing the MRI? Okay. Okay. I mean, for all these problems, we were using this PSA density and all that, right? So, so there is no safe PSA. Any PSA is abnormal. Even a normal, one PSA may be abnormal for this prostate, right? So it all depends on your clinical finding, DRE. If prostate is suspicious, even if the PSA is 1 or 2, you may need an MRI, right? So if your DRE is normal, PSA is 7, it's a 100 gram prostate, I don't think there is role of any further workup for PSA, raised PSA, because this PSA is normal for that person, not a raised PSA. And one more question was about the free PSA, and Tanu was saying that we rely more on MRI and don't look at a free PSA. So there are things that we also do. I mean, we hardly look at a free PSA. If there is PSA in the range of, where do you see free PSA? In between the range of 4 and 10, right? Or something like that? So
yes,
if
more than 40 cc prostate, we don't do a free PSA.
Right. So even in our practice, we do the same thing.
Yes.
Right? We don't do free PSA.
And 4
Even
to
if
10.
in doubt, do an MRI and take a biopsy.
MRI is really changing things.
Yeah, right.
In fact, there is some talk, there was a proposal in the recent AUA meeting that, I don't know, maybe this is not the right stage, but I mean, it was MRI is questioning biopsy.
Yeah. But recently you have had this medical legal issue being circulated in WhatsApp and other groups. Like in Tata Memorial Hospital, there was a case. They started chemotherapy without doing a biopsy.
Oh, that is bad. Even I know of a patient who is on abiraterone right now by the oncologist, never having undergone a biopsy.
Yeah.
I don't know, it's not right. Biopsies must.
Kidney cancer, it's not a must. Why to isolate prostate?
So, sir, if you can appreciate, we have enucleated the left lobe here. This is a capsule. This is a bladder neck. From below, if I show you, this is the bladder neck, almost till the midline.
Yes.
So we'll leave it here now and we'll go to the opposite side. Okay? Okay?
Okay.
So now for the right side. Again, this is the Veru. Start from here. Something has happened. Oh, okay. I think I only pressed the button. Actually, I'm having to hold this camera so hard that some buttons can be pressed.
Show us the sphincter.
On right side, this is the sphincter area. Okay?
Okay.
On left side, this is the sphincter. This.
Okay.
Of course, it's come little beyond and we have to go there. Like Srinivas sir said, scooping behind the sphincter. This is the same thing we do in T1. We go behind the sphincter and resect. Here we go behind the sphincter and enucleate. ये खुल गया. I think there are some small abscesses in this area. That's why that turbid sort of material came out. Oh, ये क्या हुआ? बॉस ओलंपस चला गया. ओह यार, ये ना टाइट पकड़ने की वजह से कई बटन प्रेस हो रहे हैं. एक बार वो स्टोर्स वाला कैमरा ट्राई करें क्या? I'll have to do a white balancing. And laser, stand by please. Actually I'm having to hold the camera so tight that some buttons are getting pressed. Okay. Laser निकालो. Yellow laser. Just give me a moment please. First piece. ये इससे 3 नंबर से है. हो गया. फिर कर देता हूँ. लाइए लेज़र.
Laser ready? I think you have taken more course from right side. Right side is more. Whoever has done biopsy. So currently what I am doing, one has to be careful in initial phase because you can just slip out into the urethra.
Tanuj?
Yes, sir.
Actually, I think we are lost.
No,
पता
no.
नहीं पता नहीं चल
So
रहा
I'll tell you what is
वापस
happening.
दिखा दे और ओरिएंटेशन
मैं दिखाता हूँ. ये हमारा इंटीरियर इंसिजन था. This is our interior incision what we had given. I'll just come back. And that is a problem with on block. So this is the left lobe enucleated. Okay. This was the anterior incision. I made some incisions here then there was some pus, that's why I had to come a little superficial. So what I'll do is I'll come back to, again as I said, from defined to undefined. This is my defined area, that is the undefined. I was in the tissue, inside the tissue, I was not happy. So I'll come back here and go to the capsule again, work on the capsule, and I will reach that area from here only. Now here I have gone a little deep, I'll show you this area. So I'll try not to go deep again, I'll just be a little superficial here. That's why I was saying that probably more cores were taken from right side. It is the tissue is not giving away very easily, like it should.
Sequelae of prostate biopsy.
Yeah. And UTI after that. We are also trying to change the camera because this one, it is difficult to rotate it because in this particular case we need to rotate quite a bit.
For HoLEP you require a rotatable camera, so.
Yes, sir. Yes. It should be loose. It is this tight, it becomes difficult because a lot of my effort is going right now into holding the camera and tightly so that I can rotate it easily with the right hand.
In course you are pressing too many buttons there.
Yeah, so now I am holding it in a different way. Now I am holding like this.
Okay. Oh, we can see.
Yeah.
So here we are getting a nice plane.
Yes, sir. So when you stopped me that time, yes, we were in a little difficult plane. So I did what I say, let's go to defined area.
Then come back to the undefined.
Yes,
yeah.
yes. Now you come here till here. This is the area where we were stuck.
Yeah. The yellowish tissue will guide you that we are into the prostatic tissue rather than capsule.
Yes.
This is the same area. We'll try to work on the capsule and reach the right area. ये लग जाएगा दूसरा.
Are you getting new camera?
Yeah, they are arranging something. I'm waiting. I don't have confirmation about same. I mean, the lab set has been brought in. But ready है? लगा के देखें. Yeah. Okay. I'll just change the camera. Light source same रहेगा. इसको और सामने कर दीजिए मॉनिटर को ना. Okay. Do you have vision from this camera?
No. Yeah. Now we are seeing. The newer camera?
Yeah, this is Carlstor's C3. It's the new camera from Carlstor's, what they've gotten into market. It is a CMOS chip compared to the...
I think it needs white balancing.
Yeah, we can do that. I'll just take it out and do it. Okay. Laser standby. White balance कीजिए please. इधर से ही करता हूँ, रुको. Okay. Better? Are you getting a better view?
Yeah.
Okay. I think there is a change now, na? In the vision.
Vision is much better.
Much better, yes, sir. So this is the area we were having some struggle. We have better vision. Let's try and define it better. We go from above. Yeah. Laser ready? क्या हुआ? नहीं ठीक है. नहीं काटने की जरूरत नहीं है. Ready, please. See how much difference just vision can make.
Rotate your hand freely.
Yes, sir.
It makes difference.
Not just that, sir. Vision is
much better.
Much better. Even brown is looking brown, not dirty brown.
True. Olympus, they have too many settings there. I mean, for cystoscope, urotoscope, laparoscopy, everywhere you have to again recalibrate it.
No, it's good for laparoscopy, sir, but for this somehow... Actually, Carlstor's, especially the last system they had, Image 1S, that was really good for endourology. Now, if you look at this fossa, it is something like a W.
Yeah.
The midline incision, from this side, we have come till here. This is the veru. And on this side, this is the fossa.
Yeah.
So, it is connected mainly in the floor of prostate now. Gradually, we will work on it. Try to get under this.
This is the point till where we had raised the adenoma from the floor. I'll just check where is it stuck. On this side, this needs to be separated. All this. We'll just check if it is still connected anywhere. Am I audible? Is it connected? I think audio visual is lost. Audio visual is lost, huh? I don't think they can hear me. हाँ आवाज़ नहीं आ रहा. कोई बैठा है नीचे?
Hello, hello.
Hello.
We are hearing you. There was a mic problem. They have changed the mic.
Okay, okay.
So I don't feel like it is attached anywhere else.
Yes, sir. There's not much bleeding also.
Yeah.
But I'm just seeing. This is the entire fossa. I'll
Yeah.
just. Now you'll be able to see better. This.
Yeah.
Yeah. Oh. Yeah.
Yeah.
Okay. This is the entire fossa.
Yeah.
Left
Nice
side.
fossa we can see all around.
Left side. This is the veru. This
Yeah.
is the sphincter on left side. This is the right side sphincter. Few tags over this. It's okay. We can fire if you want, but not required much.
It's just a sliver. Okay. Yeah. And this is the fossa on the right side. Ah, there is some tissue here. This is the one where, yeah.
Lost
So
in the play.
we will.
This is the only part that is left.
Yes, we will knock it off. This part we want to leave, whatever is here.
Thank you.
Okay. So this is the fossa on right side. This little bit of tissue, I think.
You are working with 250.
I am working with 250, yes.
Any questions from the postgraduates?
Okay, so this part I don't want to touch deliberately. It's okay.
Whatever is hanging, we can take it down.
It'll all go out, sir. If I go too much behind.
Anteriorly, that's only that. It's totally hanging, it will come down. Even if you leave it behind, it will come out.
It will all come out. It will slough out. I think.
Yeah.
I think whatever we do now will be cosmetic only. So,
true.
Anyway, we come back and see at the level of this. This is the Vero sphincter on either side. Both sides okay. This is the adenoma. The whole adenoma as one. This is the prostatic urethral mucosa. The entire thing, including the median lobe and the lateral lobe. This is one lateral lobe, this is the other lateral lobe, and we divided it in the midline. Okay, laser standby, please.
Good job, Tanuj.
Thank you, sir.
Nice fossa, and this time probably changing the camera has worked.
Yes, sir. Yes,
definitely, it makes life easier.
Yes.
Hope that modulator should work nicely.
It should.
Have you tried hypertonic saline, keeping saline inside bladder for a few minutes and thereafter attempting modulation? In case it.
I have not tried, sir. You think it can help?
People have tried, and somewhat it helps. If the modulator, like Versa cut, it's not cutting at all.
Yes.
Keeping it for 15 minutes in a hypertonic saline, provided everything else is satisfactory from patient side, it helps to soften the tissue and it will start cutting.
Okay. Maybe I will try it someday, sir.
Yeah.
So as we are coming close to the
light ये वाला on कर दीजिए.
End of the workshop.
Castros light on कर दीजिए.
Amrin, are you there?
Yes, sir. Light on कर दीजिए कोई Castros वाला.
Maybe you can come down to the
Castros light on.
First storeroom and maybe hand over the certificates to the postgraduate trainees.
On कर दीजिए. नीचे वाला light on कर.
Lot of thanks to everyone.
अरे कोई तो ऑन कर दो भाई. भैया हेलो उधर ऑन करो प्लीज. वो स्टोर्स का लाइट ऑन करो. Everyone has abandoned us here. नीचे वाला ऑन करो.
They are spellbound.
अब वो प्रेस करो.
मेरे सर्जरी देख के सब लोग just मंत्र मुग्ध हो गए.
नहीं, white button. White, no that, yes. Thank you. लाइव सिस्टम ऑसिलेटर दे दीजिए. ओके. ये विजन इज ओके.
Yeah.
लाइव स्टडी. So can you pedal please? थोड़ा ब्राइट ज़्यादा है. Pedal please. Thank you. Take this back. थोड़ा कंफर्टेबली प्लेस कर दो. यस, इधर का. चलो, रेडी है ऑसिलेटर? ओके. कटिंग को मीडियम रखिए. हाँ, इट्स ऑलरेडी इन मीडियम. ओके, थोड़ा इसको ढीला कीजिए. कहाँ अटक रहा है? आगे ले आइए. I don't think it is cutting. Are you getting tissue? Okay. नहीं, 2 बोतल चला दीजिए. दोनों. हाँ, दोनों चला दीजिए. अब क्या नहीं क्या चलेगा. सिस्टर ब्लैडर देख लीजिएगा. ठीक है. थैंक यू.
Seems looking fast.
Tanuj, any troubleshooting tips about this oscillator?
Sir, same as I mentioned in the last case, bladder should be full, hemostasis should be good. If you are not able to oscillate, first of all check the settings, check whether the suction is enough or not. Check the blade, ask whether how many times it has been used. Then if it is not oscillating, first thing we can do is inverse oscillation in the bladder itself. If it is still not oscillating, we can do inverse oscillation in the fossa. And if it is still not oscillating, then if it is small tissue only, we can catch it with a forceps or a loop. We can cut with bipolar or monopolar loop. If it is too big and oscillator fails, then better to put in a catheter. Let it become nice soft, and after 24 hours or 48 hours, you can come in again and do a oscillation. If there is too much of bleeding, better to do hemostasis and then do it. If it is still, vision is not becoming clear, again same thing, you can always do it after 24 hours.
So how this waiting for 24 hours helps?
Sir, one thing is that with the irrigation, I mean, if it is because of the vision and bleeding, then with the irrigation all the bleeding stops, and next day you will find absolutely clear vision. And if it is because of the hardness of the tissue, then as it bathes in the irrigation fluid, the tissue becomes softer. So both ways it helps. Especially in large prostate, patient should always be counseled that it can be a stage procedure. Anything more than 150 cc, it's better to tell them that it can be next day. Also, you don't want to be inside the urethra for a very long time. So there is no harm in staging if it procedure has gone long for a long time.
Moreover, the next procedure which you plan after 24 to 48 hours
Yes,
will
sir.
take very little time.
Yes.
The entire you can do
Agreed.
oscillation within 10 minutes.
Agreed. Once you have done it that way, then you will realize that why you were struggling the previous day.
Yeah, absolutely. But I feel like that the setting of Versacate,
Yes.
the suction should be full, but the
Yes.
speed should be intermediate.
Agreed, sir. Same setting I'm using right now. Because if it is too fast, then it keeps leaving the lobe.
Yeah.
Slower the speed, better the oscillation. ब्लैडर है. One more thing one can do is, if it is, just keep changing the place you are morcellating. Just hit it gently with the scope, it will change the place, and then you can hold it from another area and morcellate if it is not cutting.
This is engaging and disengaging.
Yes, 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 yes.
With time we all have learned
Yes.
how to deal with this Varsa cut.
Bladder है ना sister? Thank you.
Probably Varsa cut has listened to our prayer, now it's working nicely.
Yeah. Varsa cut is trying to woo you, sir.
This has been darling for last 1 decade.
I can see that continuously you are feeling the bladder, right?
Yes, sir.
With your left hand.
Sister is doing it, sir.
Okay.
She is my third eye. Because when you are morcellating, most of the field of vision is occupied by the lobe. So it's better that someone keeps checking that the bladder is full.
Amri?
So now we'll go to the troubleshoot number 1.
We praise too much.
Inverse musculator. Catch it, come to center, musculate. Catch it. थोड़ा टेबल अप कर दीजिए प्लीज.
It is probably best done near the trigone where the bladder mucosa is quite fixed.
Yes, sir. So I do it there only. In fact, I would even come into the fossa. You can see here.
That is much better.
टेबल अप कर दीजिए प्लीज. ऊपर कर दीजिए. कर दो अच्छे से कर दो. बस, थैंक यू. Okay. Let's see if anything else is there in the fossa. Bladder is okay. That is one orifice. That's the second orifice. There is a tissue here.
Now he is getting into a round shape.
Yes, sir. And in a large fossa, when you are in the bladder, it would go into the fossa. When you come to fossa, it will go in the bladder. Best thing is just catch it and come into the fossa and musculate here. Again, catch, try to catch, come to fossa.
We have devised various ways of doing morcellation with this versa cut. All Indian manipulations.
Yeah.
Nowhere, probably nobody has seen anybody doing upside down.
Yes.
There is a nice way of doing it.
Okay.
I think all done.
See, this is the fossa collapsing, that is the bladder.
Yeah.
बड़ा पानी खत्म हो गया. पानी खत्म हो गया. पानी खत्म हो गया. Brother. Okay. So even the fossa can collapse, just like bladder. Okay. ये लीजिए sister.
So, all done with nice fossa.
Yes, sir.
Without any bleeding.
Yeah.
Even the morcellation time was quite less as compared to the last one.
Yes.
Tanuj, I mean, you're the same surgeon, same morcellator.
Yes.
I mean, what made the difference here? We could see, I mean, you were struggling in the first case, and this time morcellation was quite easy.
So that was a bigger prostate. I don't know if someone has measured the weight, but that was a bigger prostate. Vision was an issue. It was the first case of the day. I was the trial surgeon.
Okay.
So, different OT, different camera system, different everything. And stores is somehow
comfortable.
It's friendly for HoLEP surgeons.
Okay. The morcellator behaves erratically. There's no doubt about it. You can have a nice morcellation, as in last case, but you can struggle with it even with small prosthetic size also.
True. And then those were 3 large lobes that we were dealing. And this case, it was en bloc, so that most of it was in one part. Only in the end there were 2-3 small pieces which we had to morcellate separately.
That is one of the advantages of en-bloc HoLEP.
Yes, yes. So faster enucleation, faster morcellation.
Faster morcellation.
Should I come out?
Yeah.
कुछ भी कोई भी दे दो 18, 20, 22. Sister has placed the kidney tray so that stream doesn't reach her. थोड़ा इधर दिखाना. Do you want to see the stream, sir, or is it okay? दिखाओ. Light on कीजिए. चल. चल. कुछ भी दे दीजिए सिस्टर. 20 दे दो, 22 दे दो, कुछ भी दे दो. 18 दे दो. Lasix दे दीजिए. Lasix please. नहीं नहीं नहीं. In my center I don't even use irrigation for most of the cases. It's not required. I'll show you now. So are you there with me or?
Yes, yes, we are there. We are watching you.
I'll just show you the color of the fluid that comes out of catheter. In my center, most of the cases I don't use irrigation also. But when I travel, I generally give. It depends on the departmental protocol. यूरो बैग देना सर. मैंने अभी इन्फ्लेट नहीं किया है. यूरो बैग देना. खोल के दीजिए ना प्लीज. So there is no irrigation on. Can you see this, sir?
Yeah, beautiful.
So actually, irrigation is not required in most of these cases. But there is no harm. It depends on the individual department protocol. We should go as per the protocol. Traction is not required.
Traction is not required. I mean, traction probably, it's my experience that traction never works in HoLEP. If you put in traction, you will encounter more bleeding than without traction.
More so if you have left the lobes to be morcellated out next day.
Yeah.
Actually, the size of prostate that we do with HoLEP, most of them are so big. And the maximum you can inflate this, I think, is 80 cc or 70 cc.
Yeah.
So the balloon would come into the fossa.
Yeah.
So it will not compress it as is required. कितना दिया आपने?
First वाला 20 दिया.
20, 20, 40, 55 हो गया. 65 बहुत है. One more thing, if you do a DRE at the end of any HoLEP, you will realize the real difference.
Yeah.
It's practically as if
nothing is there.
Yeah, it's a female, not male. Your skin. Someday he will require a circumcision.
Let's taste that.
जिसने पीछे किया है उसकी जिम्मेवारी है ना आगे करना. अरे रुक जा भाई. बाबा अभी रॉड स्लिट करा के मानेंगे. जाना चाहिए. Yes.
At last.
At last. So, the urine is clear, sir.
Yeah, absolutely, absolutely clear. This was clear throughout the procedure.
Yes, yes, yes. टिश्यू कहाँ है? टिश्यू दिखा दीजिए. ज़्यादातर पेशेंट होते हैं. This is the tissue we have removed, sir. निकाल दीजिए.
Can you focus it out?
Can you
Yeah,
see?
yeah. Now we can see.
It's reasonable, this much.
Reasonably, yeah.
Okay, sir. I think if there is a talk, you can go ahead with it. खोल दीजिए सिस्टर
भाई खोल दो भाई. By the way, Mumpy is our sister, and Uma is our sister. They are experienced urology sisters.
Sister has assisted so well today, all the 3 cases, and she's patiently waiting for the 4th one.
Yeah. So they are the most experienced sisters in urology, and Mumpy is our robotic surgery sister.
No, they are very good staff.
Yeah. And big applause for all of them. Yeah.
Yes. And even the anesthetists have supported very well, I think. All the patients, I think morning cases are also doing fine. Again, thank you for this opportunity. It was great to visit MEDICA Hospital.
Amrit?
Yes, sir. Come on.
सर्टिफिकेट में वो साइन नहीं हुआ सर.
एक फोटो ले लो, सर्टिफिकेट बाद में सबका सेंड करके भेज देगा.
2 ही है, बाकी सब चला गया. Thank you everybody. Thank you God of. Thank you Jitender আর রাজেন্দ্র, তোমাকে বিশেষ করে থ্যাঙ্কস. মানে তুমি এসছো. ওকে স্যার সার্টিফিকেট.
Okay. It was a pleasure having you all here, and especially the people from the Olympus company, the Luminous people, Apurva, as coordinated everything and helped us in organizing this event in a very short time actually. Maybe last Friday we were discussing about this event, and this Sunday we could do it within a period of maybe just 7-8 days. So that's a great effort and great organization skill from Ambreen basically, right? So young organizing secretary. So let's really, give a round of applause for Ambreen at least. And the whole team. This is a young department, this MEDICA hospital department. And we are between the cusp of oncology and urology. So we are doing some urology and mainly want to focus on Uro-Oncology and develop a team of which is sub-specialized into doing some dedicatedly stone work, dedicatedly lower tract work. We're trying to build this team and develop this subspecialty in the hospital. And we are looking forward for support from each and everyone. Our marketing team, Priyavrato, our branding team, everyone has been really very enthusiastic and very helpful. Because to organize an event in this time when we are overburdened with workshops and conferences, each and every day we are having some conference, some workshop. So get this events is really difficult nowadays. So thank you all for joining, coming and encouraging Dr. Ambreen Chatterjee. Yeah. So yeah, prize kya hai? Certificates. I think certificates are yet to be signed by the Dr. Mishra sir and Dr. Sujina. So we'll deliver it later on. Okay. And yeah, we'll send it. Okay. Yeah. Okay. Come. He wants photo shoot. Roman will not leave you without photo shoot. Come. Aajo sab log, aajo. Come. राजेश कम here. एक फोटो शूट कर लेते हैं. सीमा सर आ जाइए, एक फोटो शूट कर लेते हैं यहाँ पे. आ जाओ. अमृत कम. गौरव का है. कम. So एक सर्टिफिकेट दे के सर के यहाँ से एक सर्टिफिकेट दे के फोटो शूट करा लो. चलो. रहने दो. अच्छा वो चलो. सर के यहाँ से ला दो. या
से इधर देखिए. अच्छा साथ में जाए. अरे अमरीन सामने आप पीछे हमेशा पीछे कराता है. थैंक यू. Thank you. Sir, want to say something?
Thanks for inviting me. I've been a local guy here. We have been doing prostate for last, say, around 8-9 years. And we are doing prostate only. For prostate, we do only HoLEP. And this is the way to learn. Plus, since we are having back-to-back conferences now, and as Abhay was telling it, every other day you will find some conferences, some workshop going on. And that's part of the thing. 2 weeks back, probably a week back, we had a workshop at IPJMR. But here we could do 3 cases because of time constraints sort of thing. But all the 3 cases, 2 cases done by Dr. Tarun was out of world sort of thing. Because both were bigger prostate, bigger than what they were estimated to be. But he did wonderful job in enucleating. The last one, because of the better optics and camera, the things are much better. So thanks for inviting me.
Thanks for inviting me. This is my first time in Kolkata. One part of India I had not visited. So I think that's because of such great HoLEP surgeons who are there in this part. But it has been great, and it is a learning experience. Just when you go to operate somewhere, you learn a lot from those who are attending. You learn a lot by seeing others. Many things I learned from sir today. There are small things which different people do differently. Maybe he would have noted some things that I do differently, and how we can imbibe it in our practice, and that's how we can make it even better. So that is why there is a major role of these live workshops. They can be small, they can be big. Personally, I feel smaller workshops are more meaningful. There is more candid discussion. Even the junior most person will not shy away from asking something. Even at our hospital, every month we do a workshop in which we have a limit of 10 urologists. They come, and we do in theater. There is no transmission. It is inside the theater. So there's a lot of discussion. Even during those workshops, every workshop, there is something to learn for me. So there is a selfish motive also. Okay, but it helps. And I think that is the way forward for every surgical discipline. Thank you again, Dr. Abhay, for inviting me. Thank you, Boston.
Tanuj, actually, I never had dreamed that I will call you someday to my city for a workshop. We met some 10 years back or 9 years back. 9 or 10 years back. So, as a colleague, as a friends, and as contemporary during the postgraduate training periods and during exams. It's a great feeling having here in our town, our city, and coming as showing your skills. You are a great name in your field, but we could see that, your greatness here. And it was wonderful watching you doing surgery. And I hope these people have learned a lot of things from you and maybe try to achieve the same level here. Thank you. Gaurav, हो गया? Gaurav, come. Gaurav, come. So these are the shyness in our people, I would say something. कुछ तो बोलो.
So very nice experience to see these stalwarts in HoLEP surgery. So we have always heard about Dr. Srinivas and Dr. Tanuj Paul. We have been across various platforms. We have seen them giving talks about HoLEP, and today we can witness this over here live in front of us and attending the OTs. It was really a great experience. Would like to have it again sometime, and it will be better for the juniors and myself and for all the people growing and improving their skills. Thank you very much, sir.
ठीक है अभी?